off. Perfect. Thank you, Anshul. So it's day 3. We're going to dive right in. We're going to skim through, some of the slides that we typically do. The housekeeping stuff is still important, though, especially for those of us who might need a refresher or for whom this is their first day. And I love that folks are telling everyone in the chat box where they're tuning in from. Feel free to do that. So again, videos on would be delightful. Definitely want to see your faces when possible to try to replicate an in-person gathering as much as we possibly can. Again, if you don't want to, we respect that, or if you don't want to be recorded. You can adjust your view to speaker view so you can see who's talking when, unless you prefer Brady Bunch, which I tend to love. Please do keep yourselves muted when you're not speaking. That way we can stay focused, although the occasional interruption is likely to happen and sometimes a lot of fun. And please ensure your name is correct, first and last name, and your pronouns listed if you're comfortable with that. If you're not sure how to do it, you just hover over your name, right click and rename. Anna, over to you.
Thanks, Bevan, and welcome everyone to day 3 of our conference. We want to be respectful of each presenter and presentation. So again, we'll do our best to stay on time today. As you know, we have an amazing lineup of presenters and a ton of great content to cover, and we will work hard to cover it all and answer all your questions. Please type any of your questions and comments into the chat box throughout today. We'll get to as many as we can, as we've done in the past 2 days, and we can continue the conversation on our discussion forum, which we'll tell you more about at the end of today. If you're sharing any stories from the field, please be respectful and anonymize them. We want to continue to stay in touch with you after our conference. We'll add each of you to our mailing list so you can stay up to date. And if you'd like to opt out, please let Anshul know by today. If any tech issues come up or you need any support throughout the remainder of the day, please direct message Anshul, Teresa, or Juliana. Bevan, over to you.
And just to say, I can tell you were hopeful when you said tell her by today, and it says tell her by Friday. Sadly, today is not Friday. We wish it was Friday, but you still do have the whole week to let us know. All right, one quick thing we wanted to say is to promote this again, just because it's a lot of fun. We have this word search that Anshul put together. It's a lot of fun. Folks have tried it out and said that when you do it online, it colors and noises and fun things happen. So we gotta keep ourselves excited with the colors and noises. So do check that out, and Anshul can pop that in the chat box in just a moment. Anna, tell us what is happening today.
Yes, we have a great day scheduled for our final day of the conference. We'll start off this morning with a panel focusing on clinician stigma. We'll have some field presentations from some of our 2021 success stories, and we'll make sure to hear about your own successes as well. And we'll wrap up with a community roundtable and networking session.
Lots of excitement. And so this is where we're going to kind of warm you up and ask you to think about some of the complex and necessary things that have been sprinkled throughout the past couple of days, but this is a concentrated time for us to really talk about the things that you've been asking us about actually since last year's conference. There was a great question. We realized we didn't know how to answer it. We better get going on it. And a lot of it was around all of the different interdynamics around race, ethnicity, gender identity, and all of these other pieces, these intersectional pieces of identity, and how different challenges come up in communication when we're trying to talk as detailers to clinicians who might not have the right language to use around inclusivity, or to speak more plainly, may carry significant stigma towards a certain patient population. And as detailers, you've asked us, what do we do? So we want to figure that out together. We're hoping that we're going a few steps in the right direction. A big part of the direction we want to go in today as we build our 2022 inclusivity toolkit that we're really excited to launch next year is to start exploring more. We've done a focus group. We're going to tell you more about that. We're going to ask you what's going on in your minds. And then we're going to have this fantastic panel. Cannot wait for that. So Anna, tell us how we're going to start with our poll everywhere for the final day.
Yes, we are going to keep it interactive. So grab your phones and we will text the number 37607 and we'll type in NaRCAD2021 to be entered into the room.
All right. And for those of you who had this up and running yesterday, you might need to, it might say to re-sign in, but it shouldn't take long. And when you do, it'll look just like this. All right. I'm in, hopefully everybody else is in. So we're going to ask you some questions to get a sense of how this upcoming panel can support you. All right, so in any setting, what is your reaction? And it could be any setting, family, out in the world, business, whatever you got. In any setting, what is your reaction when you hear a stigmatizing comment? All right, to correct them kindly, it's jarring, you're defensive, you slouch, yes, oh geez, ugh, WTF, surprise, shock, negative, correct them, oof, shock, hurt, I panic, cringe, yes, cringe and the eye roll together sometimes, discomfort, educate, shock, uh-oh, lots of things here. Educate them, feel a loss of connection. Yes, that one really feels important. Try to counter the statement, say, seriously, really? You feel awkward, you try to role model other language. So we're seeing a lot of similar threads here. Some people are saying they're ready to rock and roll, clear up misinformation. Some people are kind of, whoa, freezing. So we've got some fight, freeze kind of stuff going on, figuring out how to deal with it. And I love this one, questioning where it came from. So trying to get into that dialogue. That's what we're going to kind of focus on today. And we're going to change to another question. Anna.
Yes. Okay. Why might clinicians have stigma towards vulnerable populations?
Anything that you think might contribute to that. All right. What are we saying?
We have stereotypes, burnout, bias, ignorance, fear, negative experiences, misinformation, perceived choice,
culture, bias. Yep.
Race, internal bias, history.
Burnout.
Bias.
That's a big one. Burnout.
Mm-hmm.
All right. We got values and religion. We have racism, perceived choice. I think that's probably meaning towards, folks where certain conditions are seen as maybe a moral failing, things like that. Bias, all in a row. Yes. All right. So we've got a lot to talk about here. Thank you guys. That's very, very thoughtful. All right. So Anna, tell everybody what we did this spring and summer.
Yes. So we'll tell you a little bit about our stigma focus groups and what we learned from them. So we hosted two 2-hour focus group sessions with 10 participants from our community. We had 5 participants in each focus group. The clinical topics that the participants who joined us detail on include opioid safety, substance use disorders, HIV prevention, pediatrics, mental health, diabetes, chronic illness. We had a really great breadth of people working on a lot of different topics. And Bevan will tell you a little bit more about these focus groups and some of the themes that came out of those conversations.
Yeah, the themes were really, some of them were not surprising. Some of them were. So, this idea of a clinician denying the impact of the clinical topic on the patient population, saying things like, I don't have those kinds of patients. That doesn't happen in my practice. Resistance to clinical change. And also, this idea of, in the first chunk, I don't have those kinds of patients and I don't want those kinds of patients. I don't want to be known as the gay doctor was an actual quote from someone in the field working on HIV. Clinicians' concerns of enabling patient behaviors. That goes back to what I said a moment ago about seeing certain medical conditions as actually a moral failing or a choice. Such as things with, related to substance use disorder. And then clinician discomfort discussing certain clinical topics. I'd like to help, but I'm still uncomfortable. I don't know where to go with that, especially as it relates to sexual health history taking and things like that. So Anna, let's talk about some of the reactions that the detailers in our focus group had when they were sharing these stories. What kinds of reactions they had to what clinicians said.
Yes, and this is very similar to what we just saw in the poll everywhere. So they shared with us that they feel uncomfortable, they freeze, they feel angry, they go into shock, they feel defensive, all things that you all expressed as well.
All right. Anna, tell us more about the resources that our focus group participants came up with as potential supports for all of you in the field.
Yes, so we had talked a lot about resources during our focus groups that we could develop to help support you all in the field. And the detailers in the focus groups asked for the following resources: scripting tools, role play, connecting with peers, self-assessment tools, resources for leadership buy-in like letter templates, recent literature, survey examples, and conference presentations. And we are doing that today. So we heard you, and we will work on developing these tools for you. That is our goal here at NaRCAD. So Bevan, over to you to talk a little bit more about our role.
Absolutely. So realizing that we are a niche field, we're a small field when you think about it, and we're a field that connects to so many other fields and kind of touch up upon the boundaries of other fields. And we're trying to talk more and more about how to integrate our work with other, complementary fields. And for a while, we've sort of thought, well, this isn't our area of expertise, so maybe we shouldn't touch it. And that is the absolute opposite of what we should be doing, any of us. When it's not your area of expertise and it needs to be, we need to bring it on home and bring it to center stage and put some light on it and figure out what we do and don't know, where we do and don't need to go. So our job here is to make intentional space for our community to discuss these issues, to discuss the discomfort, to discuss what we need, to discuss that we don't know what we need. Providing resources for you all, so that list is not, that was on the page prior, is not exhaustive. Those are just little baby ideas that we want to flesh out with all of you. So as you're thinking about this work, as you're thinking about your own experiences, and for those of you who have been lucky enough to not have this kind of interaction yet, but you might, think about how you're feeling about the potential of that coming up for you. And we can start thinking about supporting you with tools, fostering connections to each other. When we did these focus groups, so many of the participants were so sort of relieved to hear that this was happening to other people. So this can be really isolating. And the idea that we at NaRCAD could have, who knows, monthly, quarterly, some sorts of meetings to talk about the dynamics that come up where inclusivity is something that we as detailers need to have tools to apply to those conversations. And so we also want to set realistic expectations about your roles in navigating clinician stigma. It is not your job to go in and school every single clinician about inclusivity and cultural sensitivity. So we want to find that balance. How do we prepare you with what you need without you feeling like, Bevan, are you serious? Like, I have 20 minutes max with these people, and now you want me to talk to them about all of this stuff. So again, we have to think about, what is our goal? Our goal is not to go in and solve every problem related to clinician stigma. Our goal is more awareness and tools to deal in the moment with things that arise that can take you away from the important conversations you need to be having about the patients, the evidence, and behavior change, and see if there are ways you can address it with more confidence and know-how. So that's what we're working on. We're excited to be building things as mentioned. So coming in 2022, we have many toolkits for those of you who haven't been bouncing around our website. Please check it out, NaRCAD.org. And we have toolkits from everything on how to build a detailing aid and materials and all of these sorts of things, to content specific toolkits. It's time for us to have an inclusivity toolkit, and we will have subsections that do relate specifically to certain clinical topics. But I think we'll find that all of the topics that were represented by the focus groups that we ran, that Anna told you all about and that we saw on that slide, that's just touching the tip of the iceberg. Really, when there's any topic, a clinical topic where care needs to change and where patients need support, there's always the potential to have these challenges where clinicians may think, oh, this person who has obesity isn't trying hard enough, things like that. And so you can apply the potential of stigma to really any topic. With that in mind, we're a little ahead of time. And so while we're waiting for diving into this topic, and talking to the lovely Jackie Travers, Carla Foster, and Jess Alward, who I will introduce more officially in just a moment, I would love you all to pop on over to the chat box and type a comment or a type of stigma that you are most afraid to deal with as a detailer coming from a clinician. It can be something you've actually heard, or it can be something you're afraid to hear or to deal with. So take a moment and think about that. Jordan, thank you for kicking us off. Transphobia. Yes, that's a tricky one. We have challenges not just with supportive, the sexual orientation spectrum, but the gender identity spectrum. And that's a case too, where we may want to consider at NaRCAD having a tool or two in our toolbox to find ways to politely but directly, correct folks when they are mispronouncing folks, or saying or doing other things that may indicate phobia towards the trans community. Jess is sharing that political bias has come up recently. That seems like something we can hopefully just like at the dinner table. I mean, Thanksgiving's coming, people saying, let's not talk about politics, or let's not talk about religion. However, that's just maybe my avoidance. But being able to sort of contain that is something we want to talk about, Jess. Thank you for that. Mike Wilson in Rochester, New York, thank you for weighing in. And I did not mean a pun there because I hadn't read your comment yet. Weight stigma has been a hard one to tackle with medical providers because they just cite health and move on without reflection. Yes, and thinking about the evidence, especially more and more that's coming out about this idea that, obesity and weight, the evidence behind what that actually means for health outcomes, and then the fact that many clinicians assume it means certain things that it might not. You guys are rocking this. Ethnicity is a tough one, says Julia. Yes, those people, absolutely not acceptable. We need to find ways to have scripted responses to that. Christy says discrimination for disabilities and then just generally bad mouthing. Yes, so ableism, we want to look at that. Nikki brings up homophobia, which we've unfortunately heard about, not just from our stigma focus group participants, but along the way in terms of work in HIV and related fields. Vishal is bringing up not having a desire to change. So this sort of, that's just who I am. I don't see this as a problem. That's tricky, regardless of what the stigma itself is. Kettle brings up religion could be a component. Denial of issues, Carrie says, any issues? Yeah, I'm good, I got this. Yeah, it's fine. No, I'm fine. That's really frustrating when someone won't even kind of come to the table to dialogue. Allison says, stigma is situational. It is a comment that arises in the conversation. And OUD stigma is pervasive. That's opioid use disorder, for those of you not in that field. Saying things like, I don't want those people in my waiting room is an odd comment considering they're already there. And also, that's your job. And thinking about, how do you say to a clinician, well, that's funny, buddy, because that's your job, but you can't say that, or you don't feel comfortable saying that. Maybe some of you on the call do. But how do you say the things you need to say to try to get to some of that without it becoming so tangential that you can't get to your actual detailing, but where you realize if it's such an obstacle, you may not be able to make progress with that clinician. There's a lot to think about here. Darla shares rural providers saying, oh, we don't have HIV here. That's an interesting moment where we can easily just use the data. Just bring that data on home and be like, really? Let's take a look at this. So that's a case where responding to a stigmatizing comment or just an ignorance comment, right? A lot of you wrote the word ignorance in that poll everywhere, can be met with evidence, as long as there's a respect for the evidence, which we assume everyone has because we bow down to the evidence. OUD for sure, yes. Melissa Christopher from the VA says, dismissing treatment for substance use disorder as a chronic condition that responds to treatment. Melissa, I always love hearing from you. If you will not mind, I would love if we could unmute you and just have you tell us a little bit more about that. Oh, and you are muted. I think you're unmuted on our end. And I'm sorry to put you on the spot, but I'm really curious about your comment. And I'm wondering if it might mean, oh, it's a chronic condition that won't respond to treatment. So what do you think? I'm gonna ask to unmute you. All right,
Better?
there you are. Yes,
Hi.
thank you.
So I think some of the areas, we're working on in the VA is this concept of no wrong door for SUD care and really transforming all of our access to treatment across the healthcare system so that when there's an opportunity wherever the patient presents, that a clinician would feel competent and confident to engage that patient in care, and whether that's bridging them in the emergency department and getting them into chronic treatment, or whether that's happening in a primary care clinic or a hepatitis C clinic, just thinking about this opportunity. And I think, we've been tackling stigma and the concerns that are coming up where folks recognize that we are trying to transform our system, but this wasn't even the culture of treatment for training. So how do we do that at the training, dynamic? Most people are trained in a VA, honestly, through medical care. There's, whether you're a nurse, a pharmacist, a physician, we train a lot of people. How are we introducing that, early on in our engagement in medical training, and really creating a culture where the expectation is that engaging patients and offering a menu of options, because folks aren't always ready for treatment yet. And that's not unlike other disease management areas. When we think about diabetes and self-management of diabetes, how often folks are kind of
not there yet.
Denial that is what they're struggling with, and may not want to engage in individual classes or training for that. So I think trying to normalize that a bit and consider the language, introducing more harm reduction opportunities and strategies that we can engage in. And that's a shift for the VA, really. And much of what we're seeing is how do we engage that in many of our areas of care. And the other place that I think it comes up a lot is in homelessness.
Yes, and I'm seeing a note right here is one of the, oh, that's you. Homelessness stigma and what they're able to receive treatment for. Yeah.
Right, like what can a homeless person receive treatment for? Because they don't have supports, or because, there's a lot of language around that. And I do understand there's practical logistics, but I think there's also an assumption that individual can't engage in care.
That if they don't have a home, then they don't have a community. And that's an interesting thing. Yeah.
Right. And that's probably not accurate necessarily. So it's an assumption that's being made. And how can we transform how we offer treatment and so that we can actually allow patients a voice to say, yeah, that is something I'm interested in. How can I arrange care that will engage them in the current living situation that they're in? So
thank you so much, Melissa. You just dropped so many interesting ideas, and where I want to kind of pull some nuggets without oversimplifying what you're saying at all. But what I'm hearing is assumptions, ignorance, being unaware of resources, needing more training. And then it brings up to the needing more training. When were folks trained in this, right? Because things keep changing, and that's where we come in as well to say, oh, if you were trained on, how to support folks with OUD 15 years ago, and you're in maybe a rural space where maybe you don't have as much access to continuing medical education that is, keeping up with the evidence, sometimes it's literally just a gap in knowledge that translates to ignorance and comments that can be stigmatizing. So much good stuff here. 5 more minutes before we transition to the panel. You guys are on fire this morning. Narissa from Illinois Advanced says, no willingness to hear other ideas or thoughts that differ from their own. Yes, that is just extreme stubbornness and obstinance. So that's a challenge. Families of adult individuals experiencing SUD are often stigmatized as enabling. Yes. So now we're looking not just at the patient, but the patient's families. And whomever made that comment, I would love you to change the name of your organization to your real name so I can give you a high five for being so spot on about the fact that it's not just stigma toward a patient. The families are also, exposed to that stigma. And actually, our panelist, Jackie Travers, will talk a lot about that in her pediatric work. Few more comments here. Cindy says, people with OUD and medication-assisted treatment, yes, which we're hearing more and more to change any potential stigma around that to start calling it medication for opioid use disorder. Zach from Canada, our lovely Zach Dumont says, any situation where a person or population is depicted as a villain, especially, bless you, Michelle, when in reality, they are more likely a victim, right? So any othering, this is the person who's doing the wrong thing, the quote, bad thing. Winnie Ho, it is wonderful to see you. Our very own Winnie, who is part of NaRCAD for the past 2 years and transitioned to a master's program, is in the audience. And she was a big part of the stigma project. All of her energy was behind initiating and launching this. So glad to see you, Winnie. Winnie says, people talking about how harm reduction can be enabling bad behavior. So the folks who think that safe injection sites are encouraging folks who use drugs to use drugs more often. That's a great point, Winnie. Cindy says, Medicaid patients. Yes, Jackie's going to talk about that. We've got misogyny here. This is a lot. This is a lot to think about. Few more before we get ready. We've got 2 minutes before the panel. Ladies of the panel, we're going to have a lot to sort through in a short amount of time, so we'll do our best to just start making some headway. We have someone saying providers that assume that the patient will not participate in a lifestyle change program, so they're just not going to even refer them. Now, this person's not going to go to a nutritionist. This person's not going to go to an exercise group or PT, so I'm not going to even ask them, which is making decisions for people by eliminating their choice, which goes back to what Melissa is saying, is that person-centered focus, allowing folks who have limited resources to make decisions for themselves and to not assume how limited their resources are. So affording them the respect of their autonomy and agency. Kathy Dooley says, issues with those who are undocumented. Yes, that is a challenge that we also talked quite a bit about in a presentation last year related to supporting women's health, reproductive health, and making sure that women who are undocumented could receive that help. Amy Lucero from New Mexico says, it is not the PCP's responsibility to treat OUD. Yes, it's not my responsibility. I'm going to refer them out. This is not my area. So then there's this piece of what fits into primary care. What do primary care folks think fits into their realm versus what we as the evidence bringers and the behavior changers need to see in primary care. We have some anti-vax comments. I'm going to wrap on up. Lisa Bullard Cawthorn from Wisconsin. It's not just their job, but they may be in that place because an opioid being initially prescribed in the first place. Yes, so prescriptions, lots of excellent stuff here. I wish I could get into every single one. We are 60 seconds away from rocking and rolling. Lots of great stuff around OUD. This idea that sometimes the patients themselves share in the stigma. Yes, internalized stigma, internalized shame from hearing so much from the community, from potentially family, from school, other institutions, the medical community. You're not doing enough. This is on you. So that's challenging as well, and a sobering thought. Thank you for sharing that, Allison. And the last comment I am going to take is from Natasha. Some people that have a challenge with OUD and don't have a traditional address do feel like they have a community. Yes, this is something that we were touching upon when Melissa brought this up, that community can be perceived in different ways by different folks. Hello, Shelley Stewart from Southeast Florida, who made that great comment before. Folks are adding lots of great links into the chat box. This is phenomenal. And I really feel like you guys are just on fire and ready to do this work. So without further ado, I am going to introduce our lovely panelists today. Thank you so much for kicking us off with so much energy this morning. You guys are such a great community. All right, I am going to introduce these three ladies, and then I'm going to shut the slide deck down so we can all see each other and just have ourselves a real conversation about this stuff, because that's what we need to do. All right, so Jackie Travers, some of you may have been in her breakout the other day that she shared with Julia Barham. She is a clinical academic detailing pharmacist from Oklahoma, and she works with pharmacy management consultants. She's done a ton of great work in AD, especially representing Medicaid patients and mostly in pediatrics. And so she'll be talking a lot about the intersection of stigma and poverty, the family lens, and so on. Jackie, you want to say a quick hi before we get going?
Good morning. Happy to be part of this wonderful, wonderful group that is just, like you said, rocking and rolling, ready to address stigma. Yeah.
Awesome. Thanks, Jackie. Next up, we have Carla Foster. She's an epidemiologist from the New York City Department of Health and Mental Hygiene. We've been lucky to have her present before on many different topics, and very excited in the past year. Our former coworker, but still rock star, Winnie Ho, conducted an interview with Carla around academic detailing to support clinicians in supporting their patients who use cocaine. Very interesting and cutting edge topic. And so Carla will be talking a bit about that campaign, but also in general, some of the things that she's seen in her work in detailing. So Carla, can we say hi to you this morning?
Good morning, everyone. I'm thrilled to be here for this important discussion.
Great to see you, Carla. Good morning. I love the books in the background, all colorful. And last but certainly not least, we have Jess Alward. She is one of our fantastic newly minted or almost newly minted facilitators. She's got one more session to go, she's saying. She is a terrific academic detailer up in New Hampshire, mostly in the north, if I'm not mistaken, and some of the more rural areas. She works for the Bureau of Infectious Disease Control at the New Hampshire Department of Health and Human Services, and has been doing a lot of amazing work on HIV prevention and related fields. So good morning, Jess.
Hi, Bevan. Thanks for having me back this year. I'm just super excited to hear from you guys in this discussion format that we're going to have. We all have different experiences. New Hampshire is very different from New York, and I'm so excited to chat with what everybody's seeing across the country.
Awesome. Thank you, ladies, so much. It is our privilege and pleasure to have you here. So I'm going to dive right in and just ask you very briefly to talk a little bit more. I know I threw a couple things out there about your general background and the geography, just some of the things that, you know, we may think we know New York, we may think we know Oklahoma, we may think we know New Hampshire. I probably think what I know based on ignorance, not enough resources about the places, and might have a little stigma because I grew up from some of my years in New Hampshire, and there are some spaces that seemed particularly close-minded, but I don't want to be stigmatizing towards New Hampshire. So I'm going to start with Jackie and have you tell us some of the flavor of where you are in Oklahoma, the kinds of patients you support through your AD work, and the kinds of, you know, clinicians that you are that you come face to face with or virtually face to face with, and some of the topics that you talk about.
Yeah, absolutely. So I am based in Oklahoma City, which is smack dab in the middle of the state. And side note, when my daughter went on a science trip to Florida when she was 13 or 14 years old, people told her that they thought we lived in teepees in Oklahoma in, I don't know, about 2013. So yeah, misperceptions and miscommunications and stuff, it's out there. I will say, though, if you want to know a little bit about who Oklahomans are as a broad swath of people, realizing that we're kind of going away from that, just look at the colorful red and blue voting map in Oklahoma. When you have a spare moment, that just tells you a little bit about the political persuasions that have come up in the chat today. So we're a red state, the reddest of red states. So that is part of what we deal with. My background in academic detailing is almost exclusively for providers who see patients covered by Medicaid. And Medicaid, as those of you not in the U.S. might not be aware, it's our safety net health system. and it's roughly 2/3 children. And roughly another 15% is folks who are considered permanently disabled, aged, blind, disabled is the category that we talk about there. So upwards of 75–80% of the folks find themselves being in a situation where they're receiving Medicaid coverage through no fault of their own. However, a lot of these folks are seen as being a suck on the system, a drain on resources, and things like that. And so that's a little bit of things that we're going to talk about today, and we find that coming to the surface in a lot of different ways. Mm-hmm. Because I do most of my detailing in the space of Medicaid, it is pediatric focused. Like I said, 2/3 of our folks are kiddos. And so because most of these kids find themselves in a situation where they receive Medicaid, they are under-resourced, and they have an overabundance of having experienced adverse childhood experiences, or ACEs, that we talked about yesterday. And so we have a lot of mental health issues with kiddos that are covered by Medicaid, and by some of the adults that are covered by Medicaid. We have an overabundance of patients with chronic mental health illness and chronic mental health challenges and things like that. And so that's kind of a bit about my sort of bucket, if you will, of detailing.
All right. Thank you, Jackie. Much appreciation. Over to Carla to let us know a little bit of the flavor of the work in AD that she's done. Carla, tell us some things.
Yeah, so I think that one of the most interesting things about working within New York City is that while it's one of the most geographically diverse locations within the states, it's also one of the most segregated. So New York City schools, New York City housing, where people live, is actually the most segregated within the states, which is something I think that most people don't realize and wouldn't necessarily expect, especially considering just how diverse the city itself is. So I think that one of the major challenges that we experience is a siloing of how people are treated, of where people are treated, of access, and of what people feel like where they belong. So not just where they have access to go to, but if people feel like they would be able to walk into a place and feel comfortable. So I think all of this really ties into how we address stigma and treatment within healthcare within New York City. And I'm looking forward to exploring that a bit more throughout this talk.
Beautiful. Thank you, Carla. And I certainly didn't know that. I am not as surprised as I probably would be if I didn't live in Boston, which is extremely segregated as well and has a history there. And those are things I think we need to think about too, is sort of the what are the, systemic and historical, elements that of, racism, classism that trickle in to the present and into the many different realms in which we work and live. So thank you for that introduction. And Jess, tell us a little bit. I know I already gave some of it away, but tell us some things about your work so we can rock and roll knowing a little bit more about you.
Yeah, so up here in New Hampshire, that's part of New England, north of Boston, in case you didn't know. People think Boston and New Hampshire are like the same place.
Pretty much.
Yeah, I'm like 2 hours north of Boston. I often go very close to the Canada-US border when I'm detailing. And up here, we are not at all racially, culturally, religiously diverse. We're very white bread, Christian background. So we see different kinds of stigma and bias up here, a lot related to socioeconomic conditions, educational levels, the fact that folks pretty much know everybody in town. So if you're walking into your clinic with some sort of an issue that may not be something you want to have public knowledge, chances are, just because the receptionist knows what you're checking in for, everybody in town might know. I am connected to the Bureau of Infectious Disease Control, so I personally detail on anything you can catch, whether it's HIV, TB, STIs, hepatitis, all of that kind of stuff is what we focus on. And we detail primarily PCPs, family practices, internal medicine, and we're making a big push for a lot of our walk-in type convenient care clinics, because that's where we see the most need up here.
So you're talking like urgent care, same day stuff. Yep.
Yep.
I was
Places
just
where
gonna
your
say-
anonymity can stay.
Yes,
Yeah.
yes. Elizabeth, I was just going to say that anything you can catch is such a great way to capture saying that those are the areas that you work in. Thank you guys so much. All right, Jackie, Carla, and Jess, we're going to dive right in. We've been talking a lot about socioeconomics already. That's a huge intersection with social determinants of health. Can't pull those apart. Got to look at them together. So I'm going to throw this to Carla to start. You touched upon the segregation piece. What are some perceptions you've seen with the work you've done that providers may have around folks with lower socioeconomic, from a lower socioeconomic status? And if there's a way that some of that stigma came up during the cocaine use campaign, we'd love to hear about that. But really, in any way that you all have found through your work and your research, how clinicians in New York and in the areas that you all have detailed may perceive patients who are closer to the poverty line. What would you like to share about that?
Yeah, and I think this is a great question that really hits the nail on the head about so much of the work that we've been trying to do over the past 5 or 6 years. And I think while we often talk about stigma, I'm not sure that we often define it. So one definition is that stigma is a social process, which can reinforce relations of power and control, and leads to status loss and discrimination for those who are stigmatized. So I think when thought of in this way, we can better understand how stigma is both deliberate and consequential. And stigma is sometimes confused as simply being labels or stereotypes, which is part of it. But it's not a case of, sticks and stones may break my bones, but words will never hurt me. In this case, words, labels, values, actions, and ideas are all used to legitimize discrimination and have real world consequences. And so socioeconomic stigma, which really has been largely normalized, impacts almost every aspect of a person's life. And as such, it is internalized by a person in a way that makes people feel incredible shame. It decreases self-esteem and causes great stress. So in terms of the patient-provider relationship, stigma may induce the assigning of blame to a person of low socioeconomic status. For example, certain health outcomes may be dismissed as a result of a bad person doing bad things. And this can result in a lack of engagement as well as interest in treating the patient according to prescribed clinical practice guidelines. And poor care, of course, can then reinforce or translate into a cycle of poor health outcomes. And then this, of course, may lead to a provider feeling unsuccessful, possibly even angry or resentful towards their patient. And I'd also like to point out that stigma can be institutionalized as well in the form of discriminatory policies that deny access to healthcare, things such as housing, employment, and other resources that are really, really critical to quality of life. And as I mentioned in the introduction, even if access isn't explicitly denied, the use of implicit cues may lead a person of low socioeconomic status to believe that they don't belong at certain, for example, high-performing healthcare centers, and therefore they won't even attempt to seek care at these institutions. And as you could imagine, throughout the cocaine detailing campaign, this is something that we first of all had to identify before we started the campaign itself, so that we were able to train our detailers on how to be proactive and how to model the type of language and the type of interactions that we wanted the healthcare providers to have with their patients. The detailers had to be the ones to do that first for the providers themselves. And in terms of something that I've seen throughout the course of our detailing work in terms of stigma, when we were detailing in the emergency room and I was shadowing some of our detailers, we encountered a physician who was referring to frequent flyers. And this was in terms to a person who had come in for a overdose on multiple occasions. And this language was really used to dismiss the fact that these persons or these patients deserve as high care quality as a person who is, not a frequent flyer. And it really communicated a lack of empathy towards the patient, and was more than likely felt by the patient during their interactions with the healthcare provider. Those like subtle cues that people pick up on and lead to a feeling of negativity in relation to that interaction, and thus can really disengage the patient as well as the provider. So our detailing reps were able to engage with that physician afterward, and had a really strong conversation about how our actions, including our language, have a real impact on the lives and health of people who use drugs, as well as their communities. This is something that is not just directed to one person and stays there. The health of the individual impacts their communities as well. And they shared that using a non-judgmental, compassionate approach is likely to increase dialogue, and that, therefore, is more likely to create opportunities for engagement, which may, over time, then lead to positive progress in terms of the patient's healthcare journey. And, I think that despite there being stigma, which, exists within the healthcare field, all of the physicians who we interacted with have the common goal of wanting to improve the health of their patients. And so I think when we focus on the fact that there's this common end goal, the patient, the provider, those of us who work within public health, we all have this same goal. And sometimes we're just not sure of how to reach it. Or sometimes we get frustrated because we're not making progress in the way that we want to, or on the timeline that we might want to. And so we really need to take a step back and say, how can I pivot? How can I make some changes that might allow us in a collaborative way to actually reach these common goals?
I love this so much. My brain is on fire. I mean, there's so much here and I'm trying to grab all the nuggets. Thank you so much, Carla. I feel like the things that are really standing out to me, and the one thing I want to grab as a positive, because talking about this can make us feel like this is so Sisyphus-y and it's such an uphill battle. And I think the fact
it's stressful to talk about, right?
It's stressful, right? But it's also stressful for patients who are dealing with this. It's so much more stressful. We're so privileged to be able to be talking about it on from a higher, kind of vantage point, trying to figure things out. Exactly. And I think, there's the chat box is blowing up. I love so many things that you're all saying, and I'm going to try to focus and curb my enthusiasm here. But I think one thing you said of the many that stood out, Carla, is the fact that all of the providers that you saw in this ER realm wanted to do better, right? And so really looking at, well, why were they not doing better yet? And there's a key piece here that you're in an ER, right? And when we took that step back and asked folks to identify, why do we think clinicians might have burnout? And there were tons of comments. why do we think they might have, stigma? There are tons of comments, and a couple folks said burnout. Now, being burnt out is not an excuse to use stigmatizing language. I want to be very clear about that. But I think when resources are low, this piece that Carla brought up about making an intentional, aware choice to step back and look at what's going on and how you're contributing to it is something that falls by the wayside when you're skipping lunch, you're in an ER, you're working a 14-hour shift, whatever the case may be. That's still not okay. So part of it also becomes, what are the institutional pressures that, and Jerry Tennant put this comment in the chat box right on time, and I loved it. Everyone can perpetuate stigma that also influences the culture of a hospital, an urgent care, a primary care practice, right? So you may be doing your best as a clinician to be very aware, to make changes, but if that front office staff person is making a person who comes in and asks for help and an appointment feel stigmatized, some of the battle may already be lost, because what you're talking about, Carla, is that the idea of access isn't, is it available? It's, do I feel safe? Is there a trust that I will be cared for? So there's so many fantastic pieces of what you said just with our very first question. So I want to thank you for being so thoughtful and walking us through so much. And I'm so glad this is recorded, because I'm definitely going to watch it again. I want to ask, kind of take it to a sort of more of a solutions focus, or just kind of get a little closer to that. And this can be for any of the three of you. But I'd love to throw it to Jackie, because I know you work just as much with the Medicaid, especially when you said the kiddos. That really kind of hits home. Like, these are kids, and stigma is not okay to apply to any human being, but there's a certain degree to which, when you picture a kid, you picture somebody who's innocent and really does not deserve any of this. They deserve to be healthy, happy, play, not have the weight of this on them. I want to ask you this next question about how you think providers could create a more supportive environment for all patients, and especially those who have a lower socioeconomic status. And I know that that's kind of a chicken egg question, because part of it is them realizing that maybe they're not supportive first. But what are some of the things that you could see yourself or other detailers encouraging providers to do differently to support folks who are socioeconomically challenged?
Yeah, absolutely. Thank you. And not to, tug at your heartstrings even further, but every child who's within the foster care system is also within Medicaid. And so we have, those kinds of situations that they're dealing with, in addition to, hopefully, stigma that is not being lumped upon them. One of the things that I want to talk about is that there are some very practical things that providers can do to support patients with whatever the situation might be, because sometimes things you see are visual, sometimes you hear things, but there's a lot of the situations that people are facing that you're not going to see visibly, and you're not going to hear about, and it's under the surface and it's hidden, and just by kind of implementing some practice-wide changes, you can really support all of your patients regardless of what their socioeconomic situation might be. And so I will say, after this week, QR codes are going to be some of your best friends. So you can encourage providers to put some QR codes up in their office that have links to 211, which is kind of a grouping here in the U.S. of some U.S. resources, food pantries and different things like that. And so while it might just look like the patient is, popping a selfie, but they're really scanning the QR code, so they can get resources, and it can be anonymous. Just kind of something to think about on a large scale for a lot of practices is kind of looking at what their health literacy kinds of practices are. How are they communicating to all of their patients? There's some really good work out of the CDC just a few years ago that says that not much more than 10% of folks have the level of health literacy that we would like them to have to understand it. So that doesn't matter if they've got a master's degree or a doctoral degree, or they make $300,000 a year. It's across the board. We have fairly low health literacy, and so we don't want to talk down to certain groups of people or certain individuals. We want to try to elevate everyone by speaking to everyone in a way that's easily understood. And so we don't want to change our verbiage based on someone's socioeconomic status. always wanting to use person first language. We don't have schizophrenics, we have patients who are living with schizophrenia. You know, and even things like I've heard providers say, well, I'm feeling very bipolar today. Well, I think maybe what you mean to say is I'm feeling ambivalent, or my mood is fluctuating, or something like that, because we don't feel bipolar, and you know, just kind of those kinds of things. So just always remembering that person first language. And one thing we can do from a practice level is implement some screening tools, some socioeconomic questions. Just asking things like, do you have trouble making ends meet? Can sort of tell you, or do you think this person is taking their $300 medication that you've just prescribed for them? Well, you know, maybe not if they're having trouble putting food on the table. So just kinds of implementing some of those questions. Rethinking some of our policies for missed appointments. So in a lot of practices, if you miss your appointment, they charge you, or they don't let you reschedule for another couple of weeks. But if you're someone who's struggling with transportation issues, if you're someone who's depending on grandma down the road, or the bus, or whatever, or you couldn't come, your job made you stay late, you know, then that's care that you didn't get because of a policy that could kind of easily be changed. The Reach Out and Read program here in the U.S. is a great resource for providers. When kiddos are little, then they get free books. It's kind of a carrot for parents to bring them in to have a primary care visit, and so they get some books, and they can kind of implement some developmental screenings. You know, does the child turn the pages? Do the parents read? Are the parents literate enough that they're able to read to the child? And so that can really help you get some nuanced looks into what's happening within the family, and some resources that you might want to wrap around them. And so kind of on that note, yeah, go ahead.
No, I was going to say I love this so much. That's all.
Training the front end office staff in filling kind of what we can think of as a social prescription. So referrals to food pantries and clothing pantries and job postings, job websites. The public library is a great source of information. They have lots and lots of things that people can use to draw upon. So just helping the front end non-clinical staff is one way to sort of take some of that burden off clinicians and sort of put it in the front-facing roles. Because just like Jess said, these folks, they know each other lots of times here in Oklahoma. It's a small town, and so someone knows that, you know, so-and-so's spouse just lost their job, and so somebody else knows that so-and-so's spouse cheated on him and left. I mean, you know these kinds of things, and so you know that these people might be struggling right now because, you know, she doesn't have a job, he didn't have a job, you know, just these kinds of things. So putting those resources in their hands. One thing that one of the practices that I worked with also did is they created a patient council. And so they kind of asked people if they would be willing to serve on this kind of group to help the practice better address some of the non-medical needs. And so I just thought that was a really lovely thing to do, and really very, very proactive.
Jackie,
If
can
you
I
really
ask, was that patient panel volunteer, or was it paid?
It was, yeah. They just put up a posting in the lobby and said, we're putting together this patient council. We'd love to hear your thoughts. And it was, yeah, nobody was specifically asked to serve on it.
Well, the interesting thing there, though, is then if it's not paid, right, you're getting folks who are already under-resourced and probably can't volunteer their time. So then that's another thing to think about, not to get too off topic, but it's interesting to think about, well,
hey
how
guys, what's up? Welcome back. Pat McGrath.
That was just me throwing my voice. So yeah, to think about how can we get the voices of folks who are socioeconomically oppressed if we're, you know, I think it's great to have a patient panel, and also can we offer something to them within the realm of all of the things that you're sharing around these, like you said, a social prescription. I love that so much, and I think that's really key.
Yeah, so to incentivize the participation, where your point is very well taken. That it may disadvantage some people and advantage some others. If I remember right, and it's been a fat minute since they did this, I think what they did is that they allowed them. I'll get back to you. Okay, I forget exactly. They had something in place to do, and it was some kind of timing thing. Like you could arrive a little bit late to your appointment if you were part of the patient council, or something. They had some kind of wiggle room, like you were allowed to reschedule 3 appointments a year or something like that. So they had something. I don't remember exactly quite what it was, but it was.
I think we can up the ante on that, though. I think we can.
I agree. Yeah.
I'd rather
Yeah,
I'd
yeah.
rather have a sandwich than a get out of fine free pass.
Right.
But all this is to say, thank you for thinking of the ways in which, and again, I want to go back to that bullet point from a couple slides ago. What's realistic for you as detailers to actually be able to do? You're not going to come in there and change the whole policy of the clinic. Having said that, this session is exploratory right now. We're trying to get down to the tangible, but I want to be clear that at 12:15, when you go to lunch, you're not going to have all the resources you need to solve the realm of provider stigma. So just be aware too that this is exploratory. We want to bring you all in a little bit more. So feel free to start putting questions in the chat box. I'm going to ask Jess a question, and then I really want to turn it over to all of you because this is becoming so rich that I really want to make sure you have your own chances to share. Jess, I'm going to throw you one that I know you're ready for, which is, can you talk about some situations where you've witnessed clinicians either using stigmatizing terms or phrases to speak about patients or describe them, and how you may have felt depending on how sort of intense that comment was, how you feel about addressing it, just kind of a little slice of what you are exposed to in a space that you've defined as very homogenous, very white, lack of diversity. That is why I myself stigmatized New Hampshire, is when I went to high school there, I felt like I lived in a bubble. So Jess, what do you think?
So a common thing I hear from providers is like presumptive language about the type of folks that they're offering care to here in New Hampshire. Things like, well, that person just needs to stop smoking. You just need to stop smoking. Or you don't have a very good diet, do you? I hear comments about, well, did you go to college? Things like this are the kinds of comments that I hear up here in rural New Hampshire a lot. And as a detailer, when I'm listening to conversations that physicians have with their patients, or that they're relating to me about conversations they've had, I have to very carefully monitor what happens here, which some people will tell you I'm not really great at. So I have to put on, Bevan knows, and all the NaRCAD team knows, that I come out of a community theater background. So I put on my actor hat and I try to not react in a way that's
I'm going to act polite. I'm going to act polite.
I am going to not show my shock and utter like disbelief in the kind of statements that you are making to me about the way you treat your patients. And I think as detailers, we have a great ability to impact that by modeling the appropriate kind of language, behavior, interactions that providers can have with their patients. And I think if we take some of what NaRCAD taught us as detailers and then teach that to providers, that they can do a much better job. We can say, make that good eye contact, use some active listening skills, ask open-ended questions instead of closed-ended questions, to really meet your patient or your client as a human to a human, and not as a provider that is somehow greater than whoever is in the audience at that time, whether it be your staff, somebody like us who's coming into your office, or a patient. It's really, really important that we model that behavior and encourage providers to just be human beings and treat everybody as they would like us to treat them as well. I mean, I know that sounds cliche, we hear that all the time, but in the busyness of their day, they have a million things that they're trying to get through. We as detailers, I've got 4 visits I've got to do today. And we go in and we get this rote thing down that we do. And if we can just make the rote thing better, we do those role plays, we do that practice, we work on making sure that our language comes out of our mouth without a second thought, and that we treat all patients the same way, that everything will go better for everyone. Standard operating procedures for how we work with patients is super important as well. We're not going to ask this patient one set of questions, but ask this patient fewer questions because we have made an assumption that we already know the answer.
And yet that does happen. And so then it becomes, and I know I said we weren't going to get too into the practical, but my brain wants to close that gap that you just said. How do we take the standard operating procedure and make it better? And so I'm thinking, let's say I'm a detailer, which I'm not. So again, putting on the theater hat here. And Jess and I actually bonded because I also went to theater school. So a lot of crossover with AD and acting, kind of fun. But maybe not sometimes when you have to hide that look of what just came out of your mouth. And I think somebody in our poll everywhere just put, seriously, like seriously, that just come out of your mouth. You said something really spot on about the open-ended questions bit, because as you were talking, I was noticing any of these presumptive questions are yes and no, always, 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 almost always. You're probably not gonna, like work out, are you? It's like, not only is that a yes or no question, but it's like, obviously you don't want to know my answer. You're telling me what you think. You are telling me what you think disguised as a question. And so in that instance, I'm wondering, and I don't want to be the one responsible for pulling us too far from shore. I wonder how we could create scripting tools for detailers to say things like, I noticed that you just described using a pretty presumptive question. So let's say you come in and you want to know something as a detailer and you ask an open-ended question such as, how do you assess if somebody is practicing safe sex? Okay, so Jess, we're going to go down that realm. And they say, oh, well, I just say you're using condoms, aren't you? And so as a detailer, is this an opportunity for us, instead of saying oof or being like, well, you might want to try this, saying, you know what, I'm sure you don't mean it that way, but that's a presumptive question that might make someone who doesn't use condoms feel really uncomfortable admitting it. So an open-ended question there, like, tell me about any practices you might use or be thinking about using or want to use to keep yourself protected and safe when you're having sex. So again, it's not being afraid to say, hey, I'm noticing this, versus you can't say that to a patient. Are you bananas? Like, so it becomes, here's what I'm noticing, bouncing it back to you. And I love that you said, I love this idea of taking the communication techniques that we use. And I always say we, I'm not a detailer, but I like to be part of the fan club. So I'm right on the border. If
You can come with me anytime. You're close enough.
Thank you. That as a detailing community, going in and using these open-ended questions to get to the nugget of a provider's story, where we might feel stigma towards that provider when that provider seems stigmatizing towards a patient, it's a little bit of a domino effect of us having to remove ourselves and try to go at it a little bit more neutrally, figure out what the story is, what the experiences are that got the clinician to that point, and then teach the clinician to do the same thing with a patient. And that could be not, I don't want to say easy, but as simple as just doing things like modeling language, just doing things like, why do you ask about whether patients went to college? And they might say, oh, because I know there's more access to, sexual health workshops there. And it might be something completely, trying to be well-intentioned. Or it might also be like, oh, because I know if they didn't go to college, they're probably not having safe sex. And it's like, whoa, where's that link? And you can say, I'm not following. Please explain. So Jess, thank you for providing practical examples. I can see you have something else you want to say before we transition. And I know we have a ton of great questions in the chat box.
So I think it's perspective, right? The provider could be coming at the statement from a very genuine, caring kind of point of view. Like that is what they hear in their head. And as a detailer, we don't want to assume the worst about the providers we work with. So we then can't make a judgment call and take our perspective and force that on them. As many people as there are in this conference today, there are that many perspectives on a given situation. So it's not okay for my perspective or Jackie's perspective to be more accurate, better, more important to listen to than anybody else's. So part of this process too is also about really listening to what the provider is telling us as detailers, and for the provider to listen to what the patients are telling them with an open mind and without a preconceived notion about anything.
And that's tricky to do. And that's something that I feel like we've talked about at NaRCAD is every single person on this call has stigma. We don't like to say that. We like to be like, no, no, no. We're the forward thinking people. We're the ones holding a stigma panel right now. How can we possibly have stigma? And it's like, no, we all have it. And a lot of it is just stuff we don't even know exists. But it can't not exist because we have grown up in a society that has it. And so unless you are incredibly Zen and there's just something special, some sort of special sauce that we need to know about to just be completely neutral and supportive of absolutely everybody and never have any sort of judgmental thought, we all have it. And that's something we need to look at in ourselves, especially if we're going in and detailing, and not looking for perfection, not saying I'm going to eradicate this. Because I don't know that that's something we can put on ourselves as individuals. We can work towards that and have high expectations of ourselves, but also realize we are up against years and years, hundreds of years of systematic racism. So there's all these things that we would like to say, hey, we're going to create some tools and just kind of make this better. We need to be realistic, not only about how we can impact things as detailers, but also just largely what we're up against and figure out how we can move the needle in meaningful ways. And a lot of what you just said, and we're getting back to this again and again, is humanizing. If we can't humanize the provider, then we should be able to understand why they don't always use language that humanizes the patient, right? And so, and I love the focus from patient-centered to person-centered, because when you say patient, you're still looking at them through that lens. And when you say person, then you're able to think about them as Jackie said, which is just these visuals really help. Are they reading a book with their parents? Oh, that's not something a patient does. That's something a child does, or we hope that they're able to do. So thank you. And Kettle is saying, I like this meta view. The fact that we're discussing provider stigma is showing our own stigma. Yes.
Yeah,
and then, go right ahead, Carla.
I just wanted to add that one thing that we've found incredibly successful at disarming some of the discussion about stigma with providers is at the outset, we let the provider know that we are addressing stigma during this campaign because none of us are immune from the bombardment of images, ideas, and really very carefully shaped messages that we've been fed, whether it be about race, about poverty, about status. And there is something that's really important about individual privilege and identity in terms of informing how we process these messages. So we let them know that it's a universal responsibility. This isn't, a certain person that we are targeting. In order to be vigilant in identifying and challenging our own biases, and to remain open to feedback and to create a space for collective learning. And really just going back to adopting that person-centered approach to care and, really knowing what that means, like honoring the fact that each person is the foremost expert on their body and using this wealth of information that the person has to collaborate with them, to develop a personalized treatment plan. And providers, should also be able to use these experiences with the people who they encounter to advocate for inclusion of folks in the creation of policies and programs that directly impact them, because that's another place where things are really lacking. How can we develop policies and programs and projects and campaigns if we're not including the very people who we're looking to target or to reach or to impact?
And Carla, I think to just add a little spin on the end, how can we do that if we're not including them and if they don't feel welcome? So it's one thing to say, we'd like your voice. And it might be like, well, I don't want to give you my voice because I see that you do not listen to me, right? And so it also becomes, there's just so many things to think about. One thing I love that you said is this idea of universal responsibility, because it not only helps us feel like we're, kind of on the same page, it also does take off or take away this sense of someone coming in and that provider feeling, as you said, like they've been targeted, like it's punitive, that defensive status of, oh, no, I'm not like that. And so that's a beautiful way to do it. But then it also, just the word universal responsibility, whether we're applying it to looking at, stigma and being more human-centric, or whether we're talking about, like you said, kind of having a coordinated care approach to things, looking at things in a more comprehensive way with everyone's input. And this idea, like, yeah, the patient is the expert on their body and their needs, even if they haven't taken an anatomy course like you may have as an MD. And so that's important too. Lots of great things to think about. I want to go back to this great question from Narissa in Illinois. Many of us as detailers already have a level of hesitancy and nervousness to provide this clinical evidence-based info, which is already pretty concrete. What are some strategies to build confidence, comfort, openness about potentially having these conversations around stigma that are less concrete and more personal, and as she says, looser? Jackie, I want to throw that to you in terms of just building confidence and having these conversations. What are some ideas that you have?
Yeah, so I would say, for me, always keeping at the forefront of my mind this idea that keeping the relationship is just critical for everything that we're doing as detailers. So if we want to think about helping them move the needle in terms of stigma, it has to be done in the context of relationship. And so if we have any kind of a shaming mentality or something like that, then that's going to alienate them, just as them shaming their patients is going to alienate their patients from better care. So keeping it, approaching them with a sense of curiosity. I'd love to know how you think stigma is impacting your practice. Where have you seen patients express hesitancy with sharing details about their lives? And so to not come in and tell them you have stigma, fix your stigma, but to come in and get them to start going down the road of self-reflection, just like we do with prescribing patterns or screenings or whatever it is that we're trying to do, rather than saying, you know what, you're prescribing too many stimulants for ADHD, let's fix that. No, it's more, tell me how you tend to approach your treatment of ADHD. So tell me what kinds of conversations your office is having about addressing stigma. It's been all over the news, so you've probably heard that we as a healthcare system, as healthcare professionals, are thinking about addressing it. Where are you all in this journey? Just to kind of get them thinking about it. Just kind of from not to go too practical and tactical, but if you kind of experience some othering language in a detailing visit, that can kind of be an opportunity to sort of springboard a little bit gently, just kind of, so when you use this word, I'm not quite sure what you mean by this word. Tell me what that means in the context of your practice. I had a provider who used the R word, and so I said, well, tell me what that means for you, because some people use that word and they mean autism spectrum disorder, and some people use that word and they mean developmental disabilities. So tell me, when you use that word, what does that mean for you? And so then they went on to explain. I said, okay, well, you might think about using this word when caring for those patients, because this is the word they're going to hear in the context of their teacher meetings and in their individual educational programs. And when they Google, how can I help my child better, you're going to want them to Google using the right words, so just kind of some of those sorts of things.
Now, Jackie, I'm going to be pokey on this and say, just because I wouldn't be able to keep a game face there, I don't think I would say that's a completely inappropriate word right off the bat, but I would want to say that's an archaic term that some folks find very offensive and is not used anymore. Can we get into that? I really want to find a space, especially with Narissa's question around how confident can we be in any situation to say that's not a word that's used anymore, and not feel like we have to apologize for saying that. It's not like we're saying, what is the matter with you, which is what's going on in my head. But to say that's not a word that's used anymore because it's considered offensive, and it also doesn't delineate what you're actually trying to say. I'd love to know more about what you're getting at and who you're describing, and find the right word that's more person-centric. Like, does that feel like an okay thing to say? Because I really, and especially, I just want to throw this out there, those of us who are identify as women in the room and we're socialized as women are often told to lessen, to make these asks smaller, to not make themselves, not make ourselves seem aggressive or bossy. And it's like, is it okay to just be like, yeah, that's not used anymore. Let's do this. So that's something I kind of want to explore because I think folks are hesitant. A lot of folks are really hesitant. Jackie, what's your take on that? And then I'd love to turn it to the other ladies to share.
So I guess, yeah, just from my own personal experience, I kind of approach things with a combination of let's get real and bless your heart. So it's kind of bringing a little bit of truth, but also letting them know that they're not the only ones that struggle in this. And so they can start to see the error of their ways in such a way that lets them know that I'm not throwing them under the bus, but I'm letting them know that we've got a course correction here. And, like I said, it's very similar to the way we do it in some other situations that, we don't want to be prescribing 4 antipsychotics to an 8-year-old or a 3-year-old. We want to be doing better. And so the only way to do that is to talk about it.
Gotcha. Yeah. Seeing some good comments in the chat box as well. Saying, I think you mean this, it sounds like something that you use, Jackie, those kinds of framings.
I had one of the providers was expressing some racial biases. And so just kind of approached that with, I think what I hear you saying is that you might be afraid that you have some cultural biases against particular groups of people. We all have those, so it's really important that you are thinking about addressing those, because the provider said, well, I want to make sure that I'm not fill in the blank. But it was said in such a way that it was just kind of a CYA kind of situation, and they wanted to make it known. Anyway, I don't have to go down that specific too much, but yeah, just kind of letting them know that they're not alone in this journey so that they can feel empowered to start taking some steps to remedy some of their own biases.
That's helpful. Thanks, Jackie. And I can sense, there's even a discomfort talking about this now because there's so many ways that we want to be doing it perfectly. And I think it's important to say that the first step is that we're trying to address these things. I want to throw it over to Carla and then Jess to kind of take a stab at that same general question of finding that line. Yes, I mean, I'm seeing this. The relationship is key. The relationship is key. When you're hearing a word or a choice that is a little more than just a little stigmatizing, but just straight up inappropriate, what can we as a detailing community do to still maintain that relationship while addressing that and making it very clear that this is, even if it's just saying, this is a kind of word that's not used anymore and will make your patients feel like they can't trust you. I mean, is there something like that we can say? It's just kind of spitballing here. So Carla and then Jess.
Yeah, I'm so happy we're having this conversation. I think in terms of detailers becoming comfortable with talking about stigma, of course, detailers have to take a look at what biases or attitudes about stigma that they might have. So at the beginning of each of our trainings for our detailers, we passed out a list of about 15 statements. And we ask each detailer to respond to that statement with how that statement makes them feel. And this is something that they can share to the rest of the group or not, but it's statements such as, when I see a person who looks like they're homeless on the street, I feel disgusted. And there are various levels of these statements, and some of them, might be more, might elicit more responses than others, and some are more subtle. But we ask people to respond to these statements, and if they agree to them, and if not. And when we're running the training, we each pull out one of these statements that elicits a response of stigma in ourselves, or it used to. And we pull that statement out and we say, you know, this is a statement that I used to believe this about. And this is how I've learned that this statement not only is stigmatizing, but it's hurtful and harmful to a group of people. And so I think going through and having this discussion with the detailers before they begin to then talk to healthcare providers allows them to not only process some of these thoughts that that they might have in a way that's, you know, not something where someone is being called out, but in a way that is more sort of comfortable and inclusive. I think that really helps. I also think that role play, going through and role playing as much as possible with a healthcare, with a someone who is pretending to be a healthcare provider who does have a lot of these stigma issues that you might encounter, and figuring out how to respond in that moment. And then specifically in terms of how we approach this, we tend to take a very direct, but also calm and tactful approach. So if we hear a healthcare provider saying something that we know is a stigmatizing, we let them know, hey, that word is stigmatizing because. We always add the because we want the healthcare providers to understand what those words or those actions are actually doing to their patients. And as I mentioned before, I have yet to encounter a healthcare provider who does not want their patients' health to improve. Like, even like if they said things like, I don't want to see these patients in my office, or I don't have these kind of patients, none of them have ever given any like indication that they don't want to help their patients. So sometimes we have to inform them that these words or these actions are harming your patients in a certain way. And the detailing rep can let them know that I've learned that this word is harmful to this patient population or to this person group because. And that lets the healthcare provider know that, okay, perhaps this is something that I need to remove from my vocabulary. But also that here is something I might be overlooking that is unintentionally making my job harder. So I think something that is really important when you're trying to change behavior is to let people know how it's going to impact them positively if they make that change. And that can sort of be a carrot to sort of bring them along and say, your relationships with the people who you treat will improve if you are able to connect with them, and removing this language will improve that connection. And so we really like to frame it in a way of collaborating with the healthcare provider in order to help them achieve the goals that they have for their practice.
I love this so much. And it goes back to NaRCA's question of how do we take something where we're already a little hesitant about the evidence, we're already a little hesitant about making somebody feel defensive about something that's concrete, and then how do we go in with something that, as NaRCA used the word, is a little more loose? And you're talking about giving it structure. You're talking about ways that you can present it factually. This can cause harm. Here's how you could not cause harm. Here's what's in it for you. I mean, it's the same techniques to AD when you're talking about the evidence more concretely. And so I love this idea that instead of it being about, ooh, I feel uncomfortable in this moment, it can be, we've spoken with patient populations and these are the words that they need to be using. If you remove these other words that we've, found are harmful to patients, you're going to have more success, and that can look like whatever's meaningful to that patient. If you're able to have a more trusting and direct relationship and conversation with your patients, things will go quicker, right? What's meaningful to that provider? Because there will be providers out there, and we've all heard the term like not a great bedside manner. There may be providers out there who are great at what they do, but they maybe don't know how to build the warmest relationships with their patients. And so sometimes just saying, hey, you're going to get more information more quickly if someone trusts you. Here's how you build trust. Here's how these words get in the way of building that trust or put you in the wrong direction. So I love that so much. Tons of snaps. Thank you. Jess, I want to throw this to you. just sort of to piggyback on what the other two ladies said, like, where's that line between being direct, but still maintaining the relationship? And, you know, what are some things we can do to feel a little more confident going into these settings?
Sure, I know we're close on time, so I'm going to give you 3 quick things that I always try to kind of keep in my brain when this comes up. The first is really know the relationship you have with that provider, because
And Jess,
that
we're good. We go to 12:15, not 12,
okay.
so we're good. Yeah.
Know the relationship you have with the provider, like where your comfort level is with that particular individual, because you can use that to guide your response. Sometimes it's completely out of left field and it's from a provider that you never would have expected it to come out of their mouth. And maybe it's a provider you've never met before and have no knowledge about. The second thing would be that I always use I-centric language first. So sometimes I will say, I know that I have done A, B, or C, or that language is always changing and it's really hard for me to keep up with, you know, whatever. So I can take some of that on myself before you really ask them to then consider their own behavior. And it makes them feel like we're in this together. This is something that we all need to work on, not just the provider. I'm not here to teach you something. That's not my, well, I mean, I am, but I'm not here to tell you what to do, I guess is a better way to put it.
Yeah.
And the last thing that I don't think we've talked about at all is to remember that detailing visits don't end when you leave the practice. You are still going to continue to have communication with this provider and everyone in that office after you go back to your office. So you can add into your follow-up email some resources that might support inclusive language, patient relationship building, trauma-informed interview, all of those kind of things. If this happens in that visit, drop that into that follow-up email and said, here's some things we thought might help you make better relationships with your patients or answer some questions you had about appropriate language to use.
I love it so much. And it goes back to our theme about cultivating relationships for community resilience. We're thinking more and more about how our detailing community is not responsible to be like, I'm going to create all of the resources. I'm going to figure out how to get people transportation to here, here, and here. But we are there to connect to those resources. And so I love this idea to say, hey, this doesn't end when I leave the room. And it's one thing to say, you know, I keep thinking of Jackie's example because it's just created such a visual for me of how do you support the whole family? How do you think about the child as having these other elements that they need to have taken care of in order to be healthy beyond this medication? And again, it's that line of what is a detailer responsible for or not. We're not responsible for creating those resources, but if we can make those community connections to figure out what those resources are, especially if other community organizations are working on similar person-first approaches to care, then you're building allies and resources to make this work a little bit easier. Because if you're helping a provider to think about language, but then in another, you know, realm in which patients exist or people exist, there's stigma over here, it's inconsistent. And so thinking about how can we synchronize as a community on how we refer to folks who are suffering from certain conditions. And that's easier said than done, right? Because there's all these different thoughts about everything from in the chat box, from harm reduction, whether people think it does this or that. So it's not an easy, you know, snap your fingers and it's done type of thing. But I think thinking about who else is out there to help you help these providers, it doesn't need to all come from you. I want to follow up on a comment from Darla Peterson that I love so much that really illustrated your comment, Jess, around modeling. Oh, this is hard for me sometimes too. Sometimes that helps. I didn't know that this word had changed. And I'm talking about something like a term, not something like an inappropriate, completely offensive term. So Darla says, I like to say things like, I'm trying to say sterile needles now instead of clean needles. I'm working on that, like just to kind of be like, instead of saying, don't use the word clean, because don't use the word dirty and clean. It just, you're not supposed to do that anymore, right? So just saying, I'm trying to work on this too. I found out that this is what people are trying to do to be more inclusive. So that's helpful as well. And again, all about finding that balance of being direct, but also letting the person that you're trying to encourage to use inclusive, supportive language. It's about behavior change, right? It's a behavior change theory. If you tell them to do it differently, is that really what's going to work? Or if you kind of get down to the why and ask them where they are on that map, can you encourage them to take a few steps? And a lot of folks have been blowing up the chat box, saying things about motivational interviewing questions. So yeah, this is all great stuff. We have 10 minutes left. I really want all of you in the audience to think about what you would like to ask these ladies, what you're thinking about in terms of your own campaigns in academic detailing, what you're worried about moving forward as we, as a community, build this inclusivity toolkit, and what you would like to see, anything like that. Do throw that in the chat box. While we're waiting for those to come in, I do have another question that I would like to ask three of you ladies, just so we can feel like we're moving a little bit towards concrete stuff. Carla, you gave a lot of great examples of ways to almost turn the social components and the ways that patients want to be supported and feel empowered into data, if you will, into qualitative data. Do you see that as being something that's critical to moving the needle on this? Do you see it as something that, you know, with any topic where stigma exists, which is everything, that having some sort of data in hand to go in and say, you know, we polled some patients and this, you know, or, you know, this is a recommendation from so-and-so. So approaching these with a data lens, what would you say? I mean, I see you nodding fervently, so I'm going to say that that's a yes, but if you'd like to share anything, that would be great.
Yes, absolutely. Yeah, I think that this is probably one of the most important pieces of moving behavior forward, or moving behavior to where you might want it to be. So just a little background story. During the COVID-19 pandemic, I'm also activated as the Deputy Director of the Health Department's integrated a data team. And so we do a lot with looking at not only dispensing data, you know, to the public, to the mayor, but we also look at how the pandemic has impacted certain populations in different ways that we might not have been able to identify without a quantitative look. So something that we found that was very interesting, and this actually goes back to talking about the places in which people might feel comfortable, was that we found that there were certain hospitals within the city that had a dramatically significant difference in COVID outcomes, so morbidity and mortality, than adjacent hospitals. So hospitals that are in the same area, but for whatever reason, have a dramatically different outcomes in terms of deaths. And so we looked at why that might be. Is it the care that's being offered? Is there something about this patient population? Is there something that's really specific about that location? And we found that a lot of the hospitals that were having poor outcomes were severely overwhelmed during especially the first two COVID surges. And the hospitals were overwhelmed because people had a preference for certain hospitals, which related to feeling like this is the hospital that they belonged at or that they should go to. So when we really started to drill down into that, we realized that, you know, for future instances where we have the health system being overwhelmed, how can we make sure that that the burden is more evenly dispersed throughout the city, as well as how can we change these ideas about who is welcome where and who feels like they have access to certain areas or certain places. In terms of the one-on-one relationship with healthcare providers, when we go into our detailing visits, we always start off our visit with key stats, both about the topic and about stigma. And these key stats, I think, are imperative because physicians are really trained to do things based upon data. So clinical practice guidelines are developed based upon the available data, the level of data, and that determines how a healthcare provider should proceed with a certain condition. And so I think that's really a way to grab a healthcare provider's attention is if you say, we have found that this is something you can do because of this. And we can show that a certain percentage or a certain proportion of people may be impacted in a certain way because of certain actions. And it's really a way to not only be succinct, but also to show this, these aren't just ideas that we have, that we've come up with, but these are things that have been proven, that have been shown to have an actual real world impact. And we'd like to engage you to see if you may be able to have the same impact as well. So I think overall, being able to evaluate your detailing campaigns, as well as being able to come to the table, to those interactions with as much, with as many facts and as many statistics as possible to support what you're saying, and to be able to present them in a way that is succinct and direct is something that will really help to engage the provider in a way that will then help to further develop that relationship going forward.
Beautiful. Yeah, beautiful. I want to give the next couple of moments. We are running close to time. So I hate to throw this bit of a corset on your ideas, but Jackie and Jess, can I ask you to just kind of distill one thing that you feel like you would encourage folks who are nervous about approaching this to do differently? We've heard about the importance of presenting things in a cause and effect data, related way. And, we have some nuggets of ideas we want to build. But what's one thing folks who are on this call right now who might be nervous about this can do or can hear from you that might make them feel a little better about being able to do this?
Can I go first?
Sorry. Go right ahead. Go ahead, Jess.
I think the biggest thing we can do is practice, like role play. Get your team together, get your in-house staff together, and walk through what it might be like for one of these, kind of scenarios to pop up. And don't just do one kind of bias. Think about the many different kinds of biases that you might run into in a provider's office, and role play it not with just you being the detailer, but other people being the detailer too, and learn from how they might approach it. We have such a community of resources here, and hopefully a lot of us have a great community in our own organizations as well that can provide valuable experience and insight and share their knowledge of how they might handle it, and just practice. Be an actor.
Practice. Jackie, let's bring it on home. What do you think? What's one thing that folks could be doing, or one small step they could take to just feel a little more confident about going into the coming months and the next year doing this kind of work?
Yeah, so I would just say sort of, take the starfish approach. You can't necessarily make a difference in the whole ocean, but you can make a difference to the one starfish that you found and sort of helped along the way. So one little conversation, you just don't know where the ripples are going to go. So don't feel like you have to change every stigma that every provider has. Just have the one conversation with the one provider that you feel like may already be wanting to improve themselves a little bit. And so pick some of that low-hanging fruit, and then you can sort of build your confidence and see that it wasn't quite as scary as you thought. Just like when you started detailing, all of us were probably terrified, and then we got in the door and we kind of went, oh, they kind of like to have us here.
I got this.
Just start small.
Beautiful. I love this so much. I've never heard it called the starfish approach. And again, it's the same way that we convince clinicians who are like, I mean, I'm not going to fix the whole opioid crisis. And you might say, yeah, but if you prescribe naloxone to one person who uses it on a friend and saves their life, mwah, that's beautiful. That is not a small thing. So Jackie's saying the same thing. If you can go in there and low-hanging fruit, I love it. Start having conversations with folks about stigma before they say something stigmatizing. Do it with a clinician you're comfortable with and say, do you notice stigma in your own clinic? I mean, really just getting comfortable talking about this. And I want to close with a couple, there's so many comments in the chat box that this is maybe the first time where I've not been able to keep up with everything because you guys are on fire. And we are going to get all of these onto a Word document and just follow up and make sure we've captured everything. But the last thing I want to say is, and Jordan brought up a great point here in the chat box, how do we, for those of us who have positions of extreme privilege, whether it's that we're white, that we're male, that we, have, access to certain things, we're in positions of privilege, how do we look at that and not feel like we're afraid to approach things, that we're afraid to upset people, and that we're afraid, of how we'll be perceived, so we're not going to touch any of it? How do we start making strides? How do we look at our own identities? I mean, these are things that we don't have the answers to about how to do definitively, but we have to be comfortable with the discomfort. We have to be willing to go into this space because we have to believe in our ability to have an impact on the providers, who have the impact on the patients, who are the people that we are here to support. So with all of that in mind, I want to thank everybody on this panel so much. Carla, Jackie, Jess, this has been phenomenal. Thank you so, so much. Everybody, round of applause. You guys have been phenomenal. Thank you. Thank you, thank you, thank you. We're going to transition into lunch. I'm sure you guys will be able to get snacks and also have plenty of food for thought given this conversation. Please stay logged into Zoom. We don't have breakouts today, so don't go anywhere. Just shut off your camera and your mic, or you can stay in here and chit chat via the chat box if you want to connect with anyone. Thank you guys so much. Take care, and we'll see you in 45 minutes at 1 p.m. Hey, Davidson. It's great to see you, Davidson. I haven't seen you in a while, probably since our last in-person convening.
Yeah, it's been a little while.
Yeah, you look great. I love your glasses.
Thank you.
All right, everyone. So before we kick off our 2021 yearbook segment, which we're always excited about, we started doing a yearbook segment last year and it was a hit. One thing I want to note is someone asked if we would be doing breakout groups this afternoon. We are, but not the way that we did yesterday and the day before. So we won't have breakout sessions for you to choose so much as we're going to take all 150 of you and break into small groups to talk about all things detailing our strengths, our challenges, and moving on into 2022. So hopefully that makes sense, Kimberlina, and anyone else who had questions. Without further ado, I am delighted to introduce our 2021 yearbook panelists. We're going to be talking about applying successful AD approaches and some successes that each of these folks' programs were able to find. Before we get to that, though, we would love you to pop over to the chat box and talk about some of your successes. Please tell us in 2021, what are you the most proud of? It can be work in AD, but if you're really just more proud that like you're in a really great place in a relationship with your cat, like that's fine too. I want to celebrate all the wins. So go ahead and pop a win or something about your program, something you're celebrating. Really want to take some time to do shout outs to each other. So if you've got a great new colleague, if you're, having a great, like Elizabeth, great place to start. You guys just finished a hepatitis C module. Yes. Julia says staying connected remotely. That really is a success. We can look at it as we have no choice, or we can be like, you know what, we're doing a really good job. Jean Stillwell added 3 new awesome detailers to her program. Yes. Vishal has been brought to the dark side in the NaRCAD facilitation pool, and that is his success of the year. Thank you, Vishal. Trish Ron facilitated her first topic training. Rocking it, Trish. Narissa said survived doing a roundtable presentation with her colleague, Michelle. You guys did great at that. Rebecca's fully vaccinated. Yes. Courtney finished her master's and is moving into prevention. Awesome. Way to go, Courtney. Samantha has increased knowledge of detailing. Now it's blowing up. I got to keep up with you guys. Carrie is learning what AD is, beginning a career in it and understanding the importance, as is Samantha. Peter Best launched a transgender continuing education course. Amazing. That's wonderful. See, we wouldn't know these things if we didn't have this. This is wonderful. Shirag is saying he also joined the NaRCAD dark side. We're coming for everyone. We're going to bring you into the facilitation cult. Kettle in Norway says a new MHT campaign has been very well received by the providers. Yes. Effie Hill is saying 5 years of AD in Iowa. Yes. Lauren's turning 30. Oh, I remember those days. Congratulations, Lauren. Allison says, had an extraordinary session with the Virginian Medical Society discussing OUD. Beautiful. Megan is finishing 2 years of pharmacy residency to become a detailer. Christy's increasing her knowledge of AD. Michelle is growing social media platforms slowly but surely, making connections virtually and having awesome branding. Yes. Cheryl is developing great collaboration partners. Jenny got trained. Moab was losing weight. Yes, anything you feel good about. Adrian created an AD hub for detailers to have a one-stop shop for everything detailing. Beautiful. We want to hear about that. And last but not least, we have a few more. Liana is becoming a training facilitator with students on rotations. Kimberlina's learning more about AD and meeting new people. And Zach is saying, shout out for the first RX Files conference that'll be held in February. Yes. Wonderful stuff here. I know that folks are celebrating their anniversaries of having programs, a program that's been at 5 years. Hey, 5 months. Anything you're doing, you're making an impact. And last one here, ALOSA training, having a great team at ALOSA. Thanks to all the detailers doing a great job in detailing on pain and OUD. Yes, we don't always take the time to pat ourselves and our pals on the back. So thank you for taking that time. All right. So without further ado, I would love to introduce Dr. Alona Balsanova. I had the pleasure of meeting her here in Boston at one of our final in-person trainings before the current era. I have a feeling we're going to get back to a fusion new approach, and I hope to see you again, Alona. But in the meantime, she is the lead detailer at Safe Prescribe Nebraska and also the director of addiction psychiatry education at the University of Nebraska Medical Center. We are so excited to have her talk about the Safe Prescribe project for opioid safety. So Dr. Balsanova, I will turn it over to you. Good afternoon.
Good afternoon. I am so excited to be here because, like you said, I was at the NaRCAD training and I attended the NaRCAD conference just thinking to myself, gosh, how amazing, all of these successful people doing all these detailing efforts. And now here I am presenting on our efforts. So it's really exciting and it's really full circle. And I see Zach Dumont here as well. He was actually my trainer during the conference. So want to make him proud. But without further ado, I will just go ahead and begin. I'm going to talk about our academic detailing for statewide opioid safety in Nebraska. I don't have any conflicts of interest.
But we do have polls of interest.
We do.
So get out those cell phones.
Yes, I would be very curious to know what is the most challenging aspect of getting an academic detailing program off of the ground, because that is what we did and we certainly had challenges. So I'm really curious to hear what your challenges were.
Here we go. It's going to be fun to see how everything moves and flows. Organizational buy-in is in the lead. I feel like I'm doing a horse racing kind of thing. With detailer training needs trailing behind, we have resource allocation. Development of printed materials is something we hear a lot about. So I'm excited to hear what was challenging for you, Alona. But it looks like organizational buy-in is taking the lead. How does that feel in comparison to where your program was at?
Well, because we kind of transcended organizations, I think that was less of a challenge. And I'll get to talking about why that is. But I think, resource allocation maybe was one of our major ones. So including, individual time and effort. So I will launch right in and we'll get to that part. So we'll first talk about phase 1 and development, because this was a brand new program. We had gotten the OD2A CDC funding. Our DHHS, the Department of Health and Human Services, received the grant and then subcontracted with the Nebraska Medical Association, which is how I became involved as a member of NMA. And subsequently from NMA is where we found the detailers, the initial 4, which was our development team. So it was 3 paid medicine physicians and myself, an addiction psychiatrist, and we all went to NaRCAD in Boston and trained, and it was really fun and eye-opening and enlightening. But that was our original kind of small group that conceived of and developed the project. So early on, where are we going?
Sorry about that.
I
hit the button too many times. My bad. You go right ahead.
Is it, I think maybe the one before, are we one ahead?
We were here.
Okay.
And then this is the next one up. Okay.
So when we all, when we all put our heads together, we determined there was going to be 3 content areas that we wanted to detail on. That's what DHHS really wanted. So one was going to be about co-prescribing benzodiazepines and opioids, because that is something we feature in a Nebraska DHHS pain management guidance document. And we wanted to refer to that because that's our state document. The other aspect was naloxone information for prescribers. So co-prescribing naloxone is something really big we wanted to get out into our communities, which would go in conjunction with another grant for distribution of naloxone. So we wanted people to know about it. And then our third content topic was the PDMP, and to really hope to enact some behavior change around people registering and utilizing our prescription drug monitoring program. So those were our 3 content areas. We did have some challenges early on, different specialties, different types of practices, private practice, academic, et cetera. So reaching a consensus on the contents of the brochures, and those pictures that you saw earlier are actually the cover of the brochure. That's what it looks like. We have it online as well as in print. So reaching consensus on the brochure contents was a challenge amongst the 4 initial detailers. Selecting a name for the project was also challenging because we just did not know how to succinctly describe what we wanted. And then, COVID hit. So we had spent all this time preparing for these in-person detailing sessions, getting trained, getting excited, getting brochures, and then COVID hit. And we had to pivot immediately, as I'm sure so many of you did. And so we had to immediately pivot to a virtual environment and adapt and figure out how to do that. So the demands of COVID-19 really did play a role in how the rest of our detailing played out, including resource allocation. So when I'm getting dizzy. Implementation. So phase 1 was development. Phase 2 is implementation. So I'll talk about that next. So we were ready to begin detailing, and we identified primary care physicians as the initial target audience. That means internal medicine and family medicine physicians in the state of Nebraska. These clinicians were selected totally randomly from the state licensure list that our DHHS has. So again, totally random. The goal is to really make it through all of the primary care physicians. Verifying email addresses for outreach was actually a much bigger challenge than we thought, because many of the email addresses are outdated that are on the licensure list. And so we had to do some hunting down of people, of email addresses, cross-referencing, and that actually took more time than we anticipated. We also had to establish some internal processes for, what's our protocol for how many contacts are we going to attempt? What kind of follow-up are we going to do if we can't reach somebody, right? All of these really small nuanced things that are what make a detailing program a successful program. So we had to do that. We created a tracking sheet for detailers to log activity and results. So that way we could keep track of, what was going on, where the challenges, how can we intervene? And we also very quickly identified a need for more detailers, because we just had these original 4 who also have a lot of time demands. And for us, it was challenging to kind of do it all ourselves. And we realized that we needed additional detailers. So we reached out to the Nebraska Pharmacists Association, since it was actually my idea that, so many of our trainers at NaRCAD were pharmacists. I think they know a thing or two about this stuff. And so I was really excited to get to collaborate with the Nebraska Pharmacists Association. We reached out to them through writing an article in their newsletter, describing our efforts, describing what the project was all about. And we interviewed a number of candidates that then became interested from reading that advertisement. We selected 3 new detailers, 3 pharmacists who are actually all in Western Nebraska, which is wonderful because the 4 original ones are in Lincoln and Omaha, which are the 2 major cities. And we really wanted to have some reach for the rest of the state and physicians that are in the rest of the state. So additional training needs. So for our 3 additional detailers, we couldn't send them to NaRCAD because NaRCAD wasn't doing in-person training, and it happened to fall during that time. We were able to fortunately connect with the Center for Innovation and Academic Detailing, CHOW, out of San Francisco, and CDC helped connect us there. And they actually provided in-depth virtual training for us over several sessions for the new detailers. And then as a refresher course for the existing detailers, I greatly enjoyed the information they provided and the collaboration that we had with them. So our progress to date, we've completed 24 detailing sessions. 57 individuals on top of that were reached through 3 group sessions with safe prescribed materials, which we know is not the official tried and true academic detailing. However, we had a desire and requests for group sessions, and we thought it better to actually spread the wealth and spread this knowledge in any way that we could to reach the most amount of people. The ongoing challenges we are having now are just different schedules among the pharmacists and the physicians. Securing appointments with clinicians and finding compatible times are challenging. All of us have, our day job that we do 100% of the time. So then finding additional time for academic detailing is a challenge. Also, scheduling our monthly all detailer check-in meetings can be challenging as well. And just maintaining motivation. COVID is a tough time, and it's a tough time for everybody, both detailees and detailers. And so I think maintaining motivation is something we are constantly trying to work on. So we do have formal feedback with survey results. We developed a survey that we sent out to individuals that we detail. And I have some images here of some of the questions on that survey. So most respondents reported that the main topic discussed was prescribing naloxone. I was actually surprised at just how popular that topic was. It was the highest talked about topic. The second most common one was co-prescribing opioids and benzodiazepines. So the prescription drug monitoring program was very minimal. And I think a lot of that has to do with its integration into EMRs and some of the healthcare institutions, which made some of our information somewhat obsolete. But we did talk quite a bit about naloxone. The impact on knowledge. So we wanted to see whether or not the individuals who we detailed found the information beneficial in terms of advancing their own knowledge and skill set. And they reported increased knowledge of naloxone, opioid, and benzodiazepine co-prescription, as well as alternatives. They all said that their knowledge about naloxone increased some or a lot compared to before their safe prescribed session. So 92% said that they feel most confident to answer questions from patients than prior to their session, which is huge, I think. For naloxone specifically, we wanted to know whether or not the individual now plans to prescribe naloxone somewhat more frequently or a lot more frequently. And that is exactly what we saw. And de-prescribing opioids and benzodiazepines when appropriate, somewhat more frequently, a lot more frequently, about the same, very minimal, and then less frequently, also very minimal. So really, we're seeing the results that we wanted to see from the perceptions of the individuals who were detailed. And then satisfaction with the educators, with the detailers. So whether or not the safe prescribed educator would be recommended to a colleague. And in fact, we got recommendations to colleagues from individuals we detailed, which was really fun to be able to then reach out to them. Satisfaction with how the education was, how the educational material was delivered, which always was on Zoom. So 83% found that to be positive, and that the educator was knowledgeable about the topics being discussed. Again, overwhelmingly positive at 89%.
And Alona, if you don't mind me splitting hairs. You said 83% found it positive, but it looks like 100% agreed that they were satisfied. And then 83% said they strongly agreed. So if anything, this is way more than 83%. Just wanted to give you some snaps there.
Right. Thank you. Thanks for pointing that out. So that was our formal feedback. So the informal feedback is actually the most exciting, I think, to me, which was really an unexpected success. So I'm at the University of Nebraska Medical Center, and where you can go ahead to the next slide, where I detailed was here, and I detailed individuals at the Nebraska Medical Center. So with the, internal medicine and family medicine physicians with whom I met, I also met with the hospitalist team. So those are individuals who care for patients in the hospital and then outpatient. And these are frontline clinicians who are seeing patients every day. And they provided really actionable feedback. They reported challenges to prescribing naloxone in the electronic medical record. They said there's like 200 different ones. I don't know which one to select. This isn't helping me to be able to want to co-prescribe it. Also challenges in knowing when to co-prescribe. Like, I don't know when to co-prescribe naloxone. When am I supposed to do that? How do I remember that I'm supposed to do that when I am? And these were all really useful pieces of information and feedback that we then turned around and turned into action. Next slide. We then, as an institution, put the 4 most common naloxone formulations to the EMR preference list. So that way, when you look at naloxone in the EMR, you only see these 4. You can go to the database if you wish, but the first ones that pop up are these 4. So it really makes it simple. We also developed system-wide documentation tools to document naloxone discussions with patients in the EMR. So you just do a dot phrase if anybody uses Epic, and then the entire thing comes out and you don't have to retype the same thing over and over again. We also sent 2, now 3 electronic bulletins to medical staff, reminding them about the importance of naloxone and informing them of available new tools to facilitate prescribing, including a best practice advisory. Next slide. So this is perhaps the biggest change. We developed a best practice advisory for co-prescribing naloxone. So this is a decision support tool that automatically launches when ambulatory opioid prescriptions are ordered and certain criteria are met, such as concurrent benzodiazepine prescription or respiratory illness, etc. So this happens for outpatient prescriptions when somebody's getting discharged from the hospital, or if somebody is seeing a physician in the outpatient clinic. And this is exactly what it looks like. This is on a test patient. So whenever you are ordering an opioid, this box will pop up, and it already has pre-selected the intranasal naloxone. And all you have to do is click accept, and then it automatically gets added to your order, to your prescription. So then it automatically gets prescribed. And concurrently, an automated message appears in the after visit summary for the patient, explaining about naloxone, how to use it, all about it. So the patient automatically has that information. We've had some incredible results from the system-wide changes. I will say, from internal conversations with our outpatient pharmacy colleagues, in the year preceding this, in the 12 months preceding the onset of this, they filled 1 naloxone prescription in the entire year, in 12 months. And since we have gone live with this change, we have ordered over thousands at this point of naloxone prescriptions. October was even higher actually than August, that updated data, which I saw just recently. So we actually have now just transformed the reach of this program, and it all began with academic detailing. It all began with talking to frontline clinicians about what their needs were and how we can best support them, which I think is something really magical. So our future directions, we would like to do increased marketing of our program. So that way we kind of word of mouth is so far how it's working, but we had a flyer in our Nebraska Medical Association annual meeting, and that was very positive and well received and led to a detailing session. We also want to increase our recruitment of additional detailers because that was successful in adding our 3, and we'd like to expand further. And also now evaluating new detailing topics, since one of our topics, the prescription drug monitoring program, is less relevant now given other system changes. We're now thinking about what would be a good topic for around opioid safety consistent with the grant to detail about.
All right. Any closing words?
Just that I think it was so unexpected that a detailing session led to such transformational change for the largest healthcare system in our state. But it did. And I think it just speaks to the power of academic detailing. And I think it's like academic detailing is the underdog. Like people don't know about it, but it results in these amazing things that are going to help populations of people and have a wide-reaching impact. And I think that is really awesome.
That is phenomenal. And as Lisa says, yeah, such exciting results. Thank you so much for sharing this. It's really lovely. And it's just such a privilege. I just want to throw in this fact, this piece of evidence, which is I got to sit across from Dr. Balsanova at our training dinner and learn more about her. And she is fantastic. And so when I knew you were presenting, I was not surprised to see your results. So thank you so much. Any questions, please pop them into the chat box. We can also address them at the tail end of the conversation. I do see that Dr. Mizrak, who's actually going to be presenting next, is saying, I would recommend harm reduction and stigma reduction for people who use drugs for your opioid program for future iterations. But fantastic progress to date. So yeah, the more that we keep hearing about harm reduction and stigma reduction, it's really interesting. There's so many people across the US working on OD2A grants, and it's just so nice to see what progress folks have made. It seems like, you know, you guys really have some nice data here, and it is, I hope we're not the underdog. I think in some ways we're the dog no one knows about. Like you said, we're sort of like the ghost dog. And then once people find out and folks see how impactful it can be, it's actually not surprising in a way, you know, to know that you going in there and just knowing you, Alona, makes a change. It really is that human to human touch. Great work. And as your former mentor says, you've really taken the ball and run with it. Excellent work. All right. If any questions come in later for Alona, please pop them in the chat box. But in the meantime, we will now transition. Thank you so much. All right. Up next, we have Brandon Mizrak, a lovely colleague of ours and who has been in this space for it's about 3 years now, and really excited for this presentation on virtual AD for hepatitis C elimination in Louisiana. Can't wait to hear about the geography, the challenges. And Brandon is the provider network supervisor at the Louisiana Department of Health for STD, HIV, and hepatitis program. A lot of overlap. And I know that I was lucky enough to meet Brandon at the very first San Francisco Department of Public Health and New York City Department of Mental Health and Mental Hygiene's Prep Institute that we got to work at together. And so I was lucky enough to be part of Brandon's training group, and to now see him coming and bringing all the flavor. I am excited. So Brandon, over to you to kick us off with your presentation.
Thank you so much. And again, I just first want to say how happy I am to be here. Bevan, like just said, I really got my start with NaRCAD and the training here when I first started about 3 years ago with prep. And I'm so proud of the work that we've been able to do and expand it out. And I hope today you'll see through my talk that we've, I think, really been able to make a true tangible difference to the health of the state. So that's what I'm here to talk about today. First and foremost, I don't have anything to disclose. I work for the state, so I work for you. I work for the people of Louisiana, I guess is the most appropriate way. But getting into it, I think it's really important to look at first where we started with the program with hepatitis C and this elimination program that I'm here to talk to you about today. Back before July of 2019, when the Elimination Project first launched, this was essentially the snapshot that we were working off of. We had a really bad problem here in Louisiana when it came to hepatitis C. We had over 39,000 people diagnosed with the illness and living with it in the Medicaid and in the corrections system here. But we were only able to ever treat 3% of the population just due to the expense of the medications. We had well over 100,000 people at risk for it through pretty much the use of people who used intravenous drugs, with really high sequelae of the illness. Liver and bile duct cancers and the deaths associated to them were very high. Next slide. And that led us to the policy that I'm really here to talk to you about, the nation's first HCV elimination program. There are several now going on throughout different parts of the country, but I am very proud to say that we were the first one to really get off the ground with it. But essentially, this program is a very far-reaching, very kind of multifaceted look at how to address both the opioid epidemic and most specifically the hepatitis C epidemic that goes alongside of it. Our goal is to actually eliminate the disease using the World Health Organization's guidelines of diagnosing 90% of individuals with the illness and treating/curing 80% of them. And this is all based around this policy that we have called the subscription model, where our state has an unlimited access to one of the medications used to treat hepatitis C, I should say cure. So sofosbuvir, velpatasvir, brand name Eclusa. We have an unlimited access to it for our community. So it's really this massive expansion that we're trying to do and get as many people identified and cured as possible. Next slide, please. So again, this is a multifaceted approach. So we have several different pillars that really kind of hold up the tent that we are trying to utilize for this elimination program. Just in the interest of time, I don't want to go through all of these point by point, but I really want to focus on the one that I'm in charge of, which is expanding our provider capacity to treat hepatitis C. But I'm more than happy to go over any of this if you all are interested in hearing more about it later on. But when it comes to strategy 5, which is mine, before the program launched on June 15th of 2019, the only people who were allowed essentially to treat hepatitis C were board certified GI and ID doctors across the state. This was less than a total of 200 prescribers for the entire population of Louisiana, and therefore it was just not tenable that this group of individuals would be the one to spear on this program where we're trying to identify and cure hundreds of thousands of people. One of the things that's also interesting, especially when you look at our state compared to the ones just bordering us, is we are a Medicaid expansion state. And in line with that, we actually have an incredibly high proportion of people who are signed up through Medicaid. About 40% of the entire state's population receive their insurance through Medicaid. So we have a very large slice of the pie, essentially, that we're able to deal with. And one of the things we're so excited about is our ability to impact that. Next slide, please. So with the start of this program, one of the first changes that came with it was we essentially tried to get rid of all restrictions, all obstacles in place to treatment. So this means that there was no longer any sort of type of prescriber, type of doctor who could prescribe medications for this, as well as there was no limit on the prescriber type, meaning both physicians and advanced practice people as well could get in on the HCV game, so to speak. But as the unfortunate side effect of this, we have an incredibly large population of prescribers who really have not studied this topic since their training back in medical school. For so long, it was limited that they were not able to provide the care for these direct-acting antivirals. And as a result, a lot of people didn't know hardly anything about the topic. So we kind of launched this big program to get the word out. The first step in this process was creating a test and treat algorithm, essentially a step-by-step breakdown of all the labs you would want to run, everything that you would want to do to safely prescribe these medications. We're very fortunate that these medications are unbelievably effective and unbelievably safe at what they do. So quite frankly, it wasn't as difficult as possible to make this list, but we needed to get the word out to everyone. Next slide, please. So, as you can see from this graph, when the program first launched, we had a near vertical rise in the amount of people that we were finally able to treat. Much like when the COVID vaccines first came on board, there was a long list of people who were very eager to get in on this. Patients who knew that they had the virus, but were just denied treatment because their liver fibrosis hadn't progressed to a certain point. One of the things that we're so happy with is with this program, we have removed all of those restrictions as well. As soon as a person is diagnosed with the virus, no matter how far progressed it is, they qualify for treatment. And this applies to all individuals with Medicaid and in the Department of Corrections across the state. We were really very happy to see where the impact that we were having with this all. Next slide. And in the first year of everything, we were really happy with the results. So starting July 15th, that would mean that a year from there would end in July 2020, which, as you recall, was a pretty big height for the pandemic. And that really kind of started the process, interestingly enough, in March of that year. But in this first year, we were still able to cure over 5,000 people with the first time doing that, and also signing on 332 new prescribers who had written a DAA prescription for the first time. Using the data that we collected through Medicaid, we were able to get information about who the people actually were prescribing these medications and see a very big uptick up on that. So again, one of the things that I want to highlight with this is just kind of the differences between a in-person detailing year versus a virtual year in the result that we were able to have. But again, we were very proud of this first year, being able to really change and save the lives of over 5,000 people in just the work that we were able to do. Next slide, please.
Amazing. It's really amazing.
Thank you. But as you will see, and I'm sure a lot of you experienced, everything really changed in March of that year. And we had to really kind of shuffle and scramble to see what we could do to keep our program growing and keep everything moving forward. So the first thing I always say with this is so much of it was like building the plane while you were flying it, trying to understand exactly what to do. Quite frankly, I had never been trained in this world of digital outreach and marketing. I did a lot of boots on the ground work beforehand, and it was a very new process for us. But in the strategies that we had, we decided to kind of work smarter, not harder, when it came to how to target and identify people. So the first thing, as it always does back in medicine, is to go back to the data, go back to where we started about go back to the Medicaid data and see what we could do to identify the proper people. One of the things that I think is so important about this was very much the lack of people who knew that they had this virus. I mean, we were estimating anywhere from 50 to 70% of individuals currently living with hepatitis C had no idea, because it wasn't ever really asked of them. It wasn't part of the standard panel that people were getting. And essentially, they were only tested for it when they had very fulminant liver issues. If you look at this data that we have here on the furthest right-hand side of it, I think the most important number to look at there is the percent of the Medicaid population screened was only 7%. Only 7% of the people in Medicaid were ever tested for this virus, and that became a very glaring, very apparent issue that we needed to address to really just expand the screening capabilities of everyone. So next slide, please. This is where we really started to kind of come up with our new plan of how to address everything and to move forward with it. So like we just heard in the last presentation, I thought a fantastic way to do this was to reach out to family medicine residency programs to try and create word of mouth in the community that there was massive policy changes when it came to HCV, but there was a lot more that providers could do. As kind of just a brief anecdote, before this program launch, before we were able, I remember I was speaking to a group of physicians about PrEP, and I had just sort of offhandedly mentioned that we were excited that this new HCV elimination program was coming, and essentially all people would qualify for treatment immediately, as opposed to having to wait until essentially their life was threatened by the virus before qualifying for treatment. I have never seen a group of physicians get so excited in my life. The opportunity would soon be present for them. And that has really stuck with me in terms of how you create these sort of programs, creating a sense of hope and community that they can make a big difference in the lives of people that they're caring for. So again, a lot of the first sessions, like we just heard in the last session, weren't necessarily done with the one-on-one detailing that we really love when it comes to academic detailing, but really more of these kind of large grand scale presentations to just make sure that people were aware of the policy changes and use that as a way to entice them to coming to us to get more information on the topic. Another big thing that helped us with all of our outreach and our ability to connect with people was the use of CMEs. The largest hospital system in the state has a fantastic CME program that they use. We were able to partner with them, and for, I mean, I think it's honestly about $1,000 per year, we're essentially able to offer CME credits for all of the trainings that we do. So that is one way to help entice clinicians to at least come to the table. And then once they do, they realize that, oh, I very much want to learn about this and keep going. This has taken the form of 2 different Project Echo series that we run. One is a weekly series that focuses on what we call the champions training. And the second one is a monthly series that we started after we learned more about the stigma that a lot of patients were facing. This second monthly one really focuses on harm reduction and stigma reduction in medicine and best ways for physicians and other clinicians to connect to their patients. I can talk a little bit more about that later, but in addition to this, we also started doing cold calls to Medicaid providers, kind of like what we heard in the last presentation, and trying to use all the data that we've collected on who is prescribing to see where the need is greatest in the state. And this is all kind of portended by the fact that we run what we call a clinician warm line. Any time of day, 24/7, you can call, text, email, essentially me and my colleagues' cell phone numbers if you have questions about specific patients, about the HCV program, about the best way to proceed medically speaking. And we found that that was a fantastic way to keep people engaged with the program and keep writing these scripts. Next slide, please. So, yes, there we go. So I think it's pretty, no problem. I think it's important to kind of look at the results of everything that we had and kind of see what worked, what didn't work. So from the next year, the first graph I showed you was the first year of the program. This essentially is data from year 2. And across the board, we're looking at around half. The rate may be slightly more, like 65% of the number of new people who started treatment, the number of new providers. And again, this is very important. Remember that this is all in the height of the pandemic when services were just not being offered at most experiences. But I think it's really important to look at the fact that even with none of the in-person training that we had availability to, we had pretty steady success going through throughout the next year. We were still able to find many new providers, expand access, and really expand the treatment numbers for everything. I am actually very proud to say that as of the most recent tally that we had on all of these numbers, we're well over 10,000 people have been identified and cured of hepatitis C. And we have over 545 new first-time prescribers for these medications. So every month we seem to be increasing back up to the first baseline levels that we kind of had set with the program and everything. Next slide, please. So to look at it more graphically, this is exactly where we come when we talk about number of persons who started treatment for HCV. Again, I think it's very important to look at subjective information from the people that we detail. I think it's very important to look at the process by which we do anything. But at the end of the day, the real number that we're trying to create is the number of people who are cured of hepatitis C. And because of the fact that this was so isolated from so many clinicians for so long, and because the work that me and my colleagues do is the main way that this information is disseminated into the community, we can be pretty confident in the fact that the work that we do is what leads to these results. And that's what I think is so important. Again, if you extended this graph out to where we are right now, that number is still going up every single month. And we're very proud of the continuing efforts that we have for everything moving forward. Next slide, please. So I think it's important to look at kind of the qualitative results of everything, kind of what were the lessons learned from all of this information that we are beginning to see. So the first thing that I have to talk about is the lack of screening really suppresses the need for HCV care in the community. Again, because HCV was quote unquote locked down for so many people, a lot of providers never tested their patients for it. One, they thought it could be stigmatizing to their patients. And two, I have personally always been of the mindset of don't ask questions you don't want to know the answer to. And I think it fell into the same category where providers knew that there was nothing they could do to help their patients, so they weren't necessarily looking for it. But when we're talking about an illness that before COVID was the #1 infectious disease killer throughout the country, where I believe 1 to 2% of the country's population is currently living with this virus, we're really trying to emphasize the point that this is absolutely in your community. This is absolutely brewing all around you. And we needed to identify that. One of the big upticks that we had in screening was after the United States Preventative Service Task Force released their new recommendation for universal HCV screening for everyone. We have seen an increase in it. And my mentality has always been, you have to demonstrate the need for this sort of care in the community, and then offer the solution to the providers who want to be able to do something about it. So demonstrate to them that their population, their community has this virus very much present in them, and then demonstrate to them that you can help them cure it. You can help them train for it. The next thing that was very important, big lesson learned, was the amount of patients who were coming back to our linkage staff and talking about how they were stigmatized by providers who had issues with making them sign sobriety contracts, even though sobriety requirements were absolutely no longer part of the program. We wanted to treat as many people as possible, knowing that just the language they were using was hurting them. And quite frankly, it was making them want to throw their hands in the air about medical care altogether. And we're talking about a group of individuals who is one of the most stigmatized in our society. It's very important that we make sure that these people feel seen and heard and not victimized by the same people who are quote unquote trying to offer them help. So harm reduction and stigma training became a massive part of our program and our education efforts. These again came from our linkage coordinators really coming back to us and saying that, you know, I've just got off the phone with patients in tears because of what the doctor said to them or ways that they were conducting this appointment. And this led to Project Harm, which is that monthly Project Echo series I talked about. That is hepatitis addiction, stigma reduction in medicine is the topic. And it again meets monthly next Wednesday for all of you who want to come with see us. The final lesson learned that was so fascinating with it is that we identified this category of what we call super treaters. Essentially, when looking at the prescribers for people who've written DAA medications, we saw that around 70% of the prescriptions were being written by a very small percentage of the actual prescribers, most of them prescribing once, twice, maybe 3 times. And then you had people prescribing hundreds and hundreds and hundreds of times. And at the end of the day, when we're talking about ensuring access for people, I thought it was very fascinating that we see these super treaters that were really major beacons for their entire community that people would go to. This was either through word of mouth or referrals and whatnot. And all of the people who are our super treaters are regulars of our Project Echo sessions, are regulars of calling our helpline and everything along those lines. So we wanted to make sure that they had the support that they needed to keep going. So all in all, when we look at the number of people who have written prescriptions, I look at this first rate here. We have detailed around 532 individuals, prescribers on the program, and around 477 have written that DAA for the first time, leading us to what I would consider a 90% success rate when it comes to lessons to action and everything that we're doing. We had lost some momentum in the first half of 2020, but we really are building back every month, moving up from there. And so much of that comes to fostering this sense of community. You'd be very surprised to see how much just being able to connect with the same individuals on a weekly basis, being able to share their success stories has led to people wanting to come back and wanting to join and do more for the field. We also are very interested in using all of the data that we get to really make a surgical targeting system and where our efforts can most be focused to ensure that we have equal access across the state, and it's not just reserved for people living in the urban areas. And the final lesson that I would say is peer recommendation. I believe it's called the Benjamin Franklin effect, but asking a provider, asking someone that you have trained to do you a favor is actually hugely helpful for them trusting you, and also spreading the word of mouth in everything that we're doing, to making sure that your services are can be given to other clinicians that they know, other people in their vicinity. And looking forward, we, like most of you, are probably going to develop a hybrid system of this virtual and in-person detailing. Next slide, and I'll wrap it up here.
Thanks, Brandon. Yeah, we have 1 or 2 more minutes and then we need to transition, but there's so much juicy stuff on here that I wish we had all day.
No, I'm happy to do it. So one of the big things that I really just want to emphasize with all of this is that I find it is a fantastic possibility to use an all virtual system for states that are just starting with this process, for states that are working on addressing certain very key problems but don't have their own detailing programs. Obviously, I'm always in favor of communities starting their own programs and doing whatever they need to do to get the word out. But if resources are scarce and it doesn't seem like a feasible alternative, I love this idea of maybe being able to use virtual program space for people that can be anywhere in the country. Essentially, you can hire like a consultant for your field that could do the exact same work that I've been doing with virtually no support system or resources allocated to it. Quite frankly, it's just the work of me and my colleagues that do 99% of what we do in terms of going to the community and providing these educations. So I thought this was a very interesting way of looking at this as a supplemental program that other states could adapt if they wanted to. And I'm always more than happy to talk to anyone about the lessons learned from that if you'd like. Next slide.
So Brandon, we actually have to cut short on the polls, but I do have 2 questions from the chat box that I think are really fantastic. One is from Sherry Bolin, who wants to know what the uptake of cold calls was. So how did cold calls go, and what was the uptake there?
I don't have like an exact percentage that I can give you, but I would say it was actually pretty good in terms of, typically I would actually start by reaching out to the administrator of whatever sort of clinic that I was trying to get into. I'm sure, like most of you have seen, it's almost impossible sometimes to reach directly out to different doctors, and they're kind of hidden behind the gatekeepers there. But if I could work with their administrators to show that this is something that could be easily folded into their practice, talk about RVUs and whatnot, they typically appreciated that. And we're keen on getting their staff signed up, or at least passing on the message for me. And yeah, that is the way that my cold calling really worked when it came down to it. The best ways that we have is using people that we've already detailed, using kind of deputizing them to be marketing beacons for us to go and tell their friends, their colleagues, hey, this is someone that you should listen to, or you should, email this person for help.
Awesome. And we talked about cold calls. Now we're going to go the other way and go to warm lines. So talk to us about the warm line. We have a question from Christine Fishman about how did this work? Because my brain also went there of like, personal cell phone. I hope no one's calling you in the middle of the night, but I think that's what the difference is between a warm line and a hot line. So talk to us, Brandon, about the warm line.
Exactly. That is why we use the, I'm sorry, I'm also just laughing at the fact of cold calls and warm line. I never put that together in terms of that. But No, that is why we use the term warm line. We can't always promise you that we will respond immediately, but quite frankly, it's never been much of an issue. I'm very fortunate. I don't think there have been any 3 a.m. calls or frantic anything along those lines. But how it's run is myself and the other major detailer that we work with are both MDs. We have studied this field extensively and essentially just know how to answer any of the questions that would come up. Really, when it comes down to it, hepatitis C is not the most complicated in terms of the actual clinical practice and what you would need to do. And I feel like the majority of calls that we get are just people wanting to make sure that what they're doing is correct. People just essentially wanting that 1 or 2 minute chat that would say, hey, this is what I had in mind. Is this correct? And you say, yes, that's exactly what you want to do. And they say, great. And they go and they feel confident then to go out and do it. Again, the warm line has never been abused, I don't think, and it has been pretty straightforward in terms of running it.
No abuse of the warm line. And also, this is just one way of going at it. If you need to have boundaries, you can do that too.
Absolutely, absolutely.
But Brandon, I gotta say, you always go above and beyond. Thank you so much for that wonderful presentation. We're looking forward to hearing what comes next, and thanks for answering those questions. If there's any other questions for Brandon or Alona, do pop them in the chat box. And as Jackie Travers says, more than 5,000 lives saved is a win any day of the week. Well done. Thank you so much, Dr. Misrach. We're going to wrap up with an international perspective. How fabulous is that? We have Kettle Espinez, and I have to say, Kettle, I'm murdering your last name. How do you say it? I want to make sure that I'm not doing a terrible job.
I'm saying it almost the same way as you do, Espinez.
All right, pretty close. So we have Kettle here. I actually got the chance to meet him in person a few years back in the Boston office, which was delightful. He's the medical advisor and the medical program manager and the CMO at COOP, the Norwegian Academic Detailing Program. We have been so lucky to hear from him, from Harold Langus in the past, and from Roar as well, Derek Horn. And so it's so exciting for us to have you present on better opioid prescribing in Norway and all of the things that you learned that can be applied not just to opioid prescribing, but to many clinical topics. So without further ado, I turn it over to you, Kettle, and thank you for being here.
Thank you. First, I might link back to the last speaker and say something about my age. When I was in medical school, from a comment in the chat box, when I was in medical school, there was hepatitis A and hepatitis B, and then hepatitis non-A, non-B. And by now, 40 years later, I guess they're spending most half of the alphabet on the hepatitis. So that's for some development. And lately, last week, I had the option for the first time in almost 2 years to be speaking to a larger audience, giving a presentation. And as I yesterday was seeing my friend Chirag Rathod's dynamic presentation here at NaRCAD, I had to do some philosophizing about what we have been doing the last couple of years, having what I call sit-down presentations versus what we're supposed to do, stand-up presentations. And that's what I like to do, if you take the pun.
We love it. We love it.
So first, I have no conflicts of interest to declare, especially no financial connections to the pharmaceutical industry, neither from CUP nor for me. But we are funded by the Norwegian Ministry of Health and Care Services. And next slide, please. Just a few slides about COOP, the Norwegian Academic Detailing Program. We started in Trondheim in 2015, became a national program for all Norway in 2016. And the program is run as a collaboration between the REDIS, the Regional Drug Information Centers, and the clinical pharmacological departments at the 4 university hospitals in Norway. So small geographical background for Norway. We are now split in four regions, medical regions, and they are called North, South, East, West, and Mid. So Southeast is one region. And as for COOP, in 2018, we established a national organization to ensure a professional uniform operation in all the 4 health regions in Norway. Of course, the main center is in Trondheim, and we are small sectors in our capital Oslo as one of them. Next slide, please. We have performed. We are now in our 5th campaign. We are doing campaigns year by year. In 2015, we had a campaign on better use of NSAIDs. Those who want to go further into that can read an article that was published about our quite good results on changing general practitioners prescribing. And guess this is also the time to be a kind of to say that as Norwegians, we're kind of wandering between American English and British English. And in Britain, we call them GPs, general practitioners. I know you call them primary care practitioners or family doctors. So when I'm talking about GPs, I mean primary care practitioners or family doctors, because those are doctors, the providers that we are detailing to. In 2016, 2017, we had in our NSAIDs campaign, this was our first small one. We visited 213 GPs, mainly in the towns of Trondheim and Tromsø. In the next campaign, 2016, 2017, we were campaigning about better use of antibiotics. We visited a total of 1,761 GPs throughout Norway. 2018, 2019, we had a campaign on type 2 diabetes in general practice, visited a little short of 1,200 GPs throughout Norway. And then the campaign I'm going to talk about today about better use of opioids in chronic non-cancer pain. We visited 969 GPs as well as 52 GPs via e-detailing, as I'll come back to about telling you how the reason for that. And now we have our performing campaign on menopausal hormone therapy. It's in progress, but I counted before I left the office today, and we have more than 200 GPs only in mid-Norway visited.
Amazing.
So that's
amazing.
So, and the next slide, please. It's only showing one of our long-time detailers, and Katrine there in her white shirt, detailing in the GP's office on the opioid campaign.
And I believe she came to the States about 5 years ago. I remember that. And that was delightful. She was lovely and a natural. So it's so wonderful to
she's a very lovely lady.
Yeah.
And then about this campaign, which was about better use of opioids in chronic non-cancer pain. And the next slide shows the preface on our campaign material. As you can also read the figure there, that there's something weighing against the use of opioids in chronic non-cancer pain, and there's a small thing about it's weighing for it, so it's outweighed, as you can see. Next slide, please. The background for us taking part in this campaign was that we were challenged to take part in work to avoid an opioid crisis in our country, similar to the crisis that has been seen in other countries. And for us, as being detailers, our focus on opioids was mainly on that opioids being medications to be used in acute situations and only for short periods of time, and to make that come through to the providers. And if you were in need for long-term pain relief, the treatment focus should be on non-pharmacological interventions and non-opioid medications. And next slide, please.
All right, we've got a poll here. It's double
You can do that.
jeopardy.
You can handle that, Bevin. That's good.
Wonderful. Thank you for throwing me a bone. Let's pop out our cell phones. This is one of the last couple of the conference. So if you pop on over to your cell phone, who on your team handles materials development? And you don't need to say, Suzanne. You can say what their role is on your team. So we have a sense. Is this an epi person? Is this, whomever it might be? All right, we've got it's a team effort. Me, myself, and I love it. I'm the content manager, rotating topic leads, pharmacist, team effort, physician, and detailer. Lots of team efforts here, state efforts, collaboration. And I'm guessing, I love it, moi, senior detailer. So we're seeing a lot of people who are doing it themselves, Kettle, but then we're also seeing folks who do it collaboratively. And I think it's going to be really nice to transition into your next slide and look at the group that you guys use to put this all together. Very collaborative effort. Thanks, guys. In COOP, we have really actually made a decision on how this should be done. And the group should be, we are building up a group with 3 internal and 2 external
members. The internal members should be one pharmacist who's commonly employed at the Regional Drug Information Center. And then there is an MD, and he's a consultant or resident in clinical pharmacology. In this opioid campaign, he was already consultant in anesthesiology and then a resident clinical pharmacology during the campaign period. Then we want to have an outside general practitioner with a background in the field of specialty that we're doing the campaign, and in this campaign we had a general practitioner with a background in pain treatment. Then we want a hospital or specialist from the internal side of the side that can do the extra specialist part of the material. And we had the head of the pain center in the department of anesthesiology, who's a professor in anesthesiology and in pain treatment, working with us in that campaign. And then, of course, the consultant in family medicine, clinical pharmacology, who is the medical advisor in CUP. And for that campaign, it was not me, but Roar Dyrkorn, who was my predecessor, as you mentioned before. And this next slide, we had 5 key messages. The first one is that the benefit of opioid use in chronic non-cancer pain is not scientifically verified. Second, non-pharmacological interventions are central in patients with chronic non-cancer pain. The third, that you should try non-opioids as a first pharmacological intervention in chronic non-cancer pain. And the fourth, if you're going to start opioids, avoid co-medication with other central nervous depressant medications. And the fifth, if you're doing treatment with opioids, you should always comply with a set plan and be evaluated at frequent intervals. And so for the implementation timeframe was that we started out, can you do one more click for me? We started out in August, September 2019. And we're doing one-on-one visits with general practitioners or family medicine practitioners or primary care practitioners, whatever you want to call them. We were trying to spread these campaigns geographically by doing one municipality after the other. And by March 12th, 2020, we had 969 GPs visited. And by March 12th, we had the Norwegian government announced national lockdown due to COVID-19 restrictions, and that made in-person detailing visits impossible. So we had to turn to virtual visits, but that also gave us an idea to work on and study how an academic detailing intervention can affect opioid prescribing. So about the study group, first, next slide, please. From CUP, it's me and Harald Langås, which is also here tonight, and from NTNU, the Norwegian University of Science and Technology, we have Torunn Hatlenest, and from the Norwegian Institute of Public Health, or the division of the Norwegian prescription database, we have Marte Handal and Svetlana Ondrasova-Skurtveit. And the study background, next slide, please, was that visits were performed municipality by municipality. And when it came to the study, we figured out quite soon that the regions of North Norway and Mid Norway have stuck to that strategy a lot better than the other 2 regions, because they had been so in the Mid Norway and North Norway by March 12th, 2020, we had some municipalities well covered with most GPs visited, and in the other municipalities we had no GPs visited. So we clearly had a split nation, to say it that way, in a more positive way than some other nations can say. And in the Norwegian prescription database, the NaRCAD, as many of you may have heard of before, they contain the database contains data about dispensed drugs in Norway, and they can give data sorted by municipality and the municipality by the address of the patient. So what we did for the study parameters, we defined the intervention municipalities as those will have more than 75% of the GPs visited by an academic detailer. The non-intervention municipalities were the ones where we had none of GPs were visited by an academic detailer. And we decided the study period to be the 1 year before the intervention by the academic detailer and 1 year versus 1 year after the intervention. And we wanted to study the total number of opioid users, the number of new opioid users in those two, before or after the last year before intervention and the first year after intervention, the total number of opioid users that they had their opioid use reimbursed for chronic non-cancer pain, and the number of new users reimbursed for chronic non-cancer pain. And then we also wanted to do a qualitative study. So we engaged Torun Hatlenus, who is a qualitative researcher at the university, and she had were collector informants. They were doctors and pharmacists that performed a minimum of 3 total one-on-one visits, and she had 4 focus group interviews with 4 focus groups, 5 to 6 informants per group, with the same interview in all groups. And of course, the focus group interviews had to be on a digital interview platform due to the COVID restrictions. And the interview guide was semi-structured with open-ended questions. And the main questions was, what was your experience of AD visits in this opioid campaign? And the second, what was the GP's opinion of enablers and barriers in the effort to achieve better opioid prescribing in non-chronic, non-cancer pain? And next slide, please.
Oh, and one more little thing at the bottom for data analysis.
Okay, sorry, the data analysis was based on the interviews where audio recorded and analyzed using systematic text condensation. Sorry. And the results for preliminary from the qualitative study was that this campaign was different from the other ones we have gone through earlier. The focus was on communicating evidence and key messages in the brochure, and you had to frame the information so the clinicians would not perceive visit as an attack or a reprimand on their current prescription, how they're doing their prescriptions currently. And you had to show empathy and understanding for that this is a difficult topic and not being stigmatizing towards the doctors for not handling this well. The second main answer was that you had to do more emphasis on avoiding new prescriptions versus reducing the old ones, and that thus acknowledging the challenges the GPs face in regard to their current opioid prescriptions, and also make them focus more on avoiding new prescriptions. The third point was, which was a limitation, that suggested non-pharmacological interventions were not always available for the GPs. And especially in the rural parts of northern Norway, GPs did not have easy access to the alternative interventions for the patients. And as a result, they did not find them those interventions to be realistic alternatives. And the last answer from the focus groups was whether we reached the right recipients, because several informants and med GPs who talked about bad experience with pain clinics, they referred patients to the pain clinics and got them back with even more opioids than they were referred with. And that was, of course, not a good experience. And the next is and do a couple, one more click, and stop there. For the quantitative study, you see that the number of users 1 year prevalence before intervention in Central Norway and in Northern Norway on the left yellow square, and you see on the right yellow square, you can see that in mid-Norway, the number has fallen slightly, but in Northern Norway, it has risen, or it's about the same. And then you have to take into account that in the rest of the country, at the same time period, we had there was a small rise in the number of users. And if you go to Northern Norway, you see that the difference between the one more click, please. See that there, yes, thank you. You see that the difference between the before intervention and the after intervention is much less in Northern Norway than in mid-Norway, especially in the intervention group. And you can see, okay, just go on to one more, and you see for the number of incident users, you see in mid-Norway that there's a quite more, there's a same fall in the number of first year users the last year after intervention than in the non-intervention groups, which has risen slightly. And also the 2 next clicks, there's a lot of clicks here. You see the same is it's the same in Northern Norway, but as one of the problems with doing numbers like this, you see that the non-intervention communities also have less first users than the others. And that's probably due to we were not the only one doing this work. There were other campaigns going on at the same time. And next shows only the one being chronic reimbursed for chronic non-cancer pain. And you see the mid-Norway and one more. See that the number, if you see by the incidence, you see that incidence sunk from 0.1 to 0.5 is a very highly significant difference versus in the intervention group. There is also sank, but not as much. In Northern Norway, we can see the same fall. One more. But you can see that the incidence, 1 year incidence on the before intervention was significantly lower in Northern Norway than in Mid Norway. So if you have a good start out, you can't have such a good result. So that's probably one of the reasons for that. And then for my preliminary conclusions, we think that it is possible to create an intervention program that can change the way GPs prescribe opioids. We think it's very important to create campaign materials every detailer feels comfortable with. We can't say we succeeded in that totally. And even when the campaign and the materials are strong, if the regional health services infrastructure or the health service infrastructure are not as good, that can affect how other GPs can adopt the key messages we are serving. And that, I think, concludes my presentation. And there are our URL and our Twitter.
Amazing. Okay, we're running a little behind on time. I see 2 questions. Let's see if we can get to at least one. Thank you so much, Kettle. Elizabeth Fallymock from Maine wants to know, is it easier for detailers to get access to docs in Norway because of the single healthcare system as opposed to here, do you think?
No, I don't think so, because we have seen a quite big difference between the health regions. In Mid-Norway, where Roar Dyrkholm and I had been doing training with GPs for many years before starting COOP, we had really easy access. But we see in the other health regions where we don't have the same standing, it's harder to get. But with this campaign we're doing now, we are having a lot of people helping us out, both on social media and also we are having a lot. This campaign is a lot better than the former ones.
All right, one more. Can I give you one more, Kettle? You think you got it? Can we squeeze it in? Was the topic of tapering off of opioids covered in the discussions with the GPs? And that's from Alyssa Lloyd.
Yes, it was included in campaign materials, but that, I guess that was one of the things that many of the editors found difficult to discuss because of that sounds is a little more stigmatizing. So it was often ended up that discussing that avoiding creating new opioid users was a good result of this problem. But it was a part of the material tapering, and you could discuss it if the providers wanted to discuss it.
Amazing. Thank you so much, Kettle. Thank you so much to all of our presenters from the 2021 yearbook. We loved it. And thank you to all of you for sharing your 2021 successes at the beginning of the session. We have one session left. First, give yourself a 15-minute break. We're going to have some interaction. People are asking to meet with each other. Please don't be shy. Go grab a coffee, a tea, whatever you need, and we'll see you back at 2:30 ET. Please stay logged into Zoom and just shut off your cameras and mics. Thank you again, Kettle, Alona, and Brandon. We are so lucky to have you present. We'll see everybody in 15. At least we try. We try to have as much fun as we can. There are days where we kind of can't do that, but I think on the whole, one thing that Anna and I have been feeling the vibe of over the past 18 months in particular is just, you guys do bring a lot of passion and joy, and it's palpable, and we want to help you find ways to get some of the weights off of you that sometimes can get in the way for that. Whoop. There we go.
Awesome. So as you've seen throughout this conference, our community is incredibly supportive and innovative. So we want you to continue to experience that right now during this roundtable. So now we are going to hear from all of you and do a few poll everywheres.
All right, so get your phones ready. We're going to walk you through a few things to get level set because we can certainly go all over the place. So let's think about your program. And for those of you who are just starting or you're here from a different vantage point, just roll through this as you can in terms of thinking about what you hope your program will look like. So where are you starting, right? Thinking about clinical focus, program development, identifying your target audience. I'll get to you in a second to tell you when you can type something in. I'm just kind of going to talk about a landscape first. Who are you recruiting and training? Thinking about your team, your staff, and your hiring, integrating community aspects. And then how are you building capacity and sustainability? Who are your program managers? I probably shouldn't say managers plural because some of you really have one, or as someone said at a former poll, me, myself, and I does everything from content development to detailing and managing oneself. So if that's you, we see you, we appreciate you. How do you work within public health and health systems? And then of course, getting to that point we all hope we can get to with resources and time and forethought, which is evaluation and assessment. How are you tracking your progress? How are you collecting your data? Do you need to report to a specific funder? And if so, with what? So thinking about all these areas, take a look at the black words on the right as some options, but also think of other options too. Our question is, signing on to poll everywhere, what is a strength of your program or organization? When you think my program is really strong at X, I want to know what is the first thing that comes into your head. And don't say you don't have any strengths because that is just silly business. All right, my team, beautiful. We love to hear that. If you've got a strong team, anything is possible. Hiring good people. Legacy, I'd love to know what that means. Whoever wrote legacy, if you feel like chatting in the chat box, I'd love it. The detailer herself, materials, strength and numbers. 5 years of great work. I know that that is probably Jordan's team. Excellent support from managers. Lauren Regier, yes, call people out if you want. Julia Barham, content development again, enthusiasm, awareness, planning, just seeing so many great things that I can't even keep up with. Training opportunities, all of these things. Some of them are sliding down to the bottom, so I apologize if I couldn't, can I do this? Is it gonna let me do it, Anna? All right, it's not gonna let me do it, and we're gonna figure that out for next year. Chuck R, you're awesome. Also, you have a really cool kitchen. We noticed it behind you, and I really like it. Staff with experience, all this great stuff. So what I'm loving seeing here is it's really largely about people. And that is something you can't pay for. You can get a great graphic designer, you can get great clinical content, but if you don't have the people to get it to the front lines in an impactful way, that's a piece of your program that needs the most strengthening. So when we're asking you, what's the strength of your program? And we see this, that is what we want to see. And for those of you who don't feel like you have a strong team yet, we're going to help you build one. All right. Next up, where do you need the most support? So that's a way of saying, not what are your weaknesses, but where are the gaps, right? So you've got these strong teams, you've got good clinical content, all of this stuff. Where do you need the most support? Yes, getting in the door. My goodness, that is going to be our albatross forever. Getting providers to meet us. Yes, marketing, scheduling, more scheduling, getting providers, deployment, access, dedicated staff, getting providers to meet us, eval, scheduling, communication, all of these different things that really seem to be about, yes, more funding equals more capacity. How do we actually get people to talk to us? This is important. This is the thing we've been hearing about the most really since we've started. And it really is so context dependent based on your geography, the culture of the clinics that you're visiting, all of these different things. So what I'm seeing here is not too much about strong teams, maybe getting some more staff on board, sure. But no one is saying here that the issues are the teams. So here's where we really get excited, because then we can do some problem solving that's so specific to these tangible things, like how do I prepare my evaluation? How do I stay up to date? And some folks do need that connection. Maybe your team is one person or a half of a person who's spending the other half of their time doing a totally different job. Shout out to Zach Dumont and many of you who are doing that kind of work. So let's talk a little bit about how we're going to get out of the way and get you guys together. Because we at NaRCAD can certainly tell you what we've heard, but you guys are the ones doing the work. So we're going to talk a little bit about that. And before we do, I just want to encourage you. I know you all have said you want more networking. Some of you are more shy than others, and that's okay. Try to be a little brave and start talking. It'll be just as awkward as if you were in person at one of our receptions, holding a cocktail and trying to meet new people. And sometimes that's easy for us, and sometimes that's not. So lean into that and do your best to try to start up a conversation. All right, next slide. Anna, talk to us about how this is going to work.
Yes, so we will get you into breakout groups of 5 or so peers. So this is a time where you'll be able to connect with your peers, share ideas, and network. You can exchange contact information if you wish as well. If you're having trouble starting the conversation, have the person whose name is first in the alphabet speak first, things like that. Try to have fun, relax, and this is a really nice opportunity to network with one another. And Bevan will talk a little bit about the discussion questions.
Okay, don't feel like you have to memorize these. Our awesome program coordinator, Anshul, is going to drop them in the chat box, and that's going to go with you into the breakout room. So this is pretty easy peasy. Introduce yourself in 60 seconds. I'll go around and do that. And then each person talk about the strength you chose. And if you didn't end up typing one, come up with one, because we know you have one, even if it's that you're all by yourself and you're doing your best to keep on going and keep on keeping on. And then share an area where you need support and chat with each other about that. So if I'm in a group with Narissa and I say, hey, I'm having trouble really building a team, and I know she's got an army of 30 people, which she does, to lean on, I'm going to say, can you help me? Or if I didn't know that, she might say, hey, I know a little bit about that, let me help you. So please don't be shy. And definitely, if you can't get going, go, as Anna said, by the first letter of your first name, which means Vishal and Zach, you are going to be last in line, and that's okay. All right, Anna.
All right. So we will see you all in 15 minutes. You should receive a prompt momentarily to enter the room. The discussion questions are in the chat box. Please turn your video on if you can. Request help from the host on your Zoom menu bar if you need assistance at any point during the session, and we'll let you know when there's 5 minutes left. So good luck, have fun.
We will see you at 2:55 ET. Enjoy yourselves, and just go ahead and click right on the link on your screen. Let us know if you're having any trouble. Good to see you, Juliana. Are you in the RA office?
Yes, I was going to say I'm in the office today, so I got the mask on.
Yeah, gotta stay safe. For those of you who are listening, we are heading into breakout groups. If you can check out the prompt on your screen. And go ahead and select. If you're just listening, we're going to be quiet as mice for the next 14 minutes. So you can keep doing what you're doing. All right. So since not every... Thank you, Anshul. Without further ado, oh, we do have a few folks coming back. All right. We're going to start back up again as people trickle back in. So we're going to ask you all to hop on over to the chat box because we want to know what you talked about. So you can choose either of these questions or both. Type about your advice infusion. What did you infuse each other with? So either what advice did you get in your breakout that was meaningful or impactful, or what advice did you give that was meaningful or impactful, or at least that seemed to be. You can talk about the topic area. You can say specifically what was said that felt meaningful. So take a moment and think about that. Hopefully everybody got a chance to chat. All right, Jane, thanks for kicking us off. Opioid for use disorder programs. So talking more about how those work. Amy says, one need for support was that providers no-show to detailing visits, and the good advice was to call providers or email or text within 1 to 2 minutes if they no-show. We've also heard that a sort of preemptive, hey, this meeting's coming up in 15 minutes can help. Kelsey says, we had 2 small and 2 large detailing groups, and the large detailing groups had great advice on how to expand funding. Yes. Same as Effie, way to engage providers when you don't have as much funding. Tony from Alosa says pharmacy education on opioid use disorder from Natasha in Louisiana. That's wonderful. Vishal says, we talked about successes and how we all have to get creative in our outreach and in how we conduct our detailing sessions. Danielle says implementing post-visit surveys. Layla says statewide anti-stigma campaign in Iowa. So cool. I want to hear more about that. Zach says patience and persistence. It is well worth the time and effort. Increasing provider interactions can be a long and arduous process. Let's see. Wow, you guys are on fire. Lauren says challenges with technology. How much should we worry? How much should we prepare? Robina says, detailer introductory videos for outreach. Yes. Charles seconds what Effie said. Anna Gribble from Maryland, scheduling visits and getting your foot in the door, how to do that. Michelle from Illinois says, I shared the pros and cons of a large detailing program. Excellent. Renee says, suggested that people from different regions in one state that didn't know the others who were doing this work to find a way to meet and learn more about each other and support each other. Yes, 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 that is beautiful. Sarah McDougall says, recruiting prescribers challenges. It is really nice to hear that this challenge is common. Not only is it common, it is the #1 challenge. Recruiting providers by far and wide is the #1 challenge that we hear about. And I'm so glad, Sarah, that you received some great tips for all the different ways you can reach out. Megan says, helpful tips for successful virtual visits. Laura Hunter says, I appreciated Natasha's perspective to not sweat the small stuff. Yes. Laura shares that she's paranoid of messing up the technical aspect. In case you hadn't noticed, Laura, I've done that over the past 3 days and we're all still standing, so it's okay. Sounds like Natasha had an impact on folks to say not to worry, it'll be okay, things like that. Elizabeth Garcia says, it was great to hear how a colleague worked in her previous experiences as a nurse and a care manager to really connect with providers. Yes, the relational aspects, the experience aspects. A few more here. Cindy Biederman says, we talked about the challenges of virtual detailing, but also the unexpected benefits in provider engagement. Yeah, and looking at a hybrid approach is terrific. Nikki Shubin shared the Your Life Iowa website information and anti-stigma media campaign. Awesome, so cool to see that. Charles says, ways to engage providers without funding. Kimberlina says, let's keep pushing forward. We're all in this together. Narissa says, utilize other phrases to describe AD since most providers don't know what it is. Trusted messengers of focused education. Yes, I'm an outreach provider. Nobody knows what AD is. I don't think they ever will, and that's okay. It's not a sexy term. If Jerry Aborn is on the call right now, I apologize for saying that, but it is not a sexy term. We want to make it something that people can grab onto. So being able to pivot in terms of what you describe it as is key. Amy says another need for support was educating providers on what AD is. Same thing, trusted messenger. Great, so you guys were in the same group. Wonderful. Carrie says revisiting addressing co-prescribing of naloxone and how providers can talk about opiate safety with patients. Janet says be persistent and you will get it. Beautiful. Lauren says we need to get a positive role model for academic detailing onto a successful Netflix series. Yes, you're right, Kettle. Educational outreach was Jerry's original term. I stand corrected. The freedom of a small AD program. You guys are on fire. Let's see, a lot of stuff about a TV series. And I like this, the final one from Tony. I liked last year's NaRCAD stating the ambassadors of the evidence. That is also a Jerry quote. So wonderful. Narissa, do not volunteer us as the people for the Netflix series, although I would do that. I think Jess would do that with me as well. All right, beautiful. I love this. So we're going to talk about themes here. These are a lot of the different things that came up over the past couple of days, and I'm just so excited to try for us here at NaRCAD to capture these. And so staying in the present moment, you know, as much as you possibly can, to remember that what you've accomplished today is enough to celebrate the wins of all sizes. And that person first approaches are appropriate for everyone, including you. Parentheses, self-care is key. Take a break for safety's sake. Explore those stigma conversations even when you're uncomfortable. We can't prepare for everything, so let's just try it and see what we learn and come back for support. Qualitative data plus storytelling plus quantitative data is a recipe for success. Try to find that balance. Bring on the empathy, evidence, and the patience with yourself and clinicians. Do not try to do it all. Ask for help, and that goes together with this last one. Supportive colleagues are your AD fam, and that includes us. That includes everybody at this conference. It includes people you haven't met yet. So if you're feeling isolated and you're in a small program, we are here for you, which really brings it on home. Remember, it's all about the relationships. It's the relationship you have with your providers. It's the relationship your team members have with one another. It's your relationship to yourself. And it's your relationship to the, you know, the evidence, knowing what you have to share is not just something you're passionate about, but that it can actually help people live healthier lives. And we've heard so much these past 3 days about the impact of AD. A year from now, I really want to hear that we're not the underdog, that we're not the unknown niche field. What's that? What's academic detailing? I want to hear a little more from all of us that we're getting into the inside. We're going into the inside. People are learning more about how impactful that we are. And so our job here at NaRCAD is to bring things, the visibility up. We keep trying to do that every year, more and more, and focus on the great work you all have done. All right, Anna, over to you to do our final poll everywheres.
Yes, back to your phones, please. What is something new that you want to try that was inspired by your peers at this conference, whether that be in the breakout groups we just had or over the past 3 days?
Acting. Yes. Yes.
QR codes.
Yes.
Poll everywhere. Helping reduce stigma. McFlurries. Cold calling. A lot of QR codes. I love that.
People love it. Cold calling with a question mark.
Warm lines. Online booking.
Yes. QR codes for the win.
Oh, definitely.
All right. Bring it on. Bring it on more and more. I mean, QR codes really seems to be the MVP. You keep
addressing difficult conversations. I love that one to end with.
All right, next one. What is one thing you need to make your work successful in 2022? Shared decision-making tools, teamwork. Anna, did I skip a poll? Did I miss one?
You did not. This is right.
All right, perfect. NaRCAD, you need us. Oh, I'm so glad you need us. We do not want to be defunct. More money, yes. We hope we can get you that somehow. Passion. Oh, you need some passion. Yeah, let's help amp it up. Teamwork, providers to meet you. Yes, we're gonna help. The end of COVID, yes. Or at least a place where it's in a contained space. Academic connection, training, motivated staff, more time and dedicated resources. For travel to resume, yes. We are hoping. Vishal says he's going to volunteer to share the passion. Vishal, you have more than enough of that. A few more in-person visits. Yeah. So I'm sensing a bit of a going back to something that feels comfortable, but also moving forward into sort of this new era and finding that balance. Perfect. All right, next one. All you, Anna.
All right. What is one thing you're looking forward to that's keeping you going? This does not have to be AD related. This could
And
be
this is from the
anything.
last one too, to say help with burnout. We are here for you on that. That was left over from the last one. Back to you, Anna.
Awesome. People are keeping you going. Yes.
Yeah. Oh yeah, anything at all. Something that is keeping you going in your life. A snack.
Travel, my first virtual visit, Vishal's energy, going to the movies, end of COVID again, meeting prescribers, in-person NaRCAD 2022, energy drinks, my awesome team.
Baking, cannoli, football.
Football. I love
Travel.
those.
Cannoli. Yes.
Yes. I thought that was you. Zach's glamour
That's
shot.
it.
Yes.
Vacation, holidays.
Vodka. Gosh. Holidays. Burnout help again. Yep. Love it. In-person NaRCAD conference 2022. Ooh, cross those fingers. We just applied for a grant to make that happen and to have a mid-year hybrid approach where some of you are in person, some of you are online. So cross your fingers. Smiles. Yes. Smiles keep you going. It is true. It is true. My awesome team. What a lovely thing to end on. So great. All right. Specifically, someone said they needed NaRCAD. Tell us what you need from us. What is something you wish we could give you? And I know family, I know you don't want to be family with us. So that's from the last one. Nice people to work with, the opportunity to network more, to see you in person. I know we miss you too. Training, more generalized AD. Yeah, not topic specific. Got you. Learning from others, the opportunity to network more again. Bevan, everyday infusions. I'm going to make a tea out of me. Advanced AD training, more role play. People don't say that much. I saw vodka again. I want to know who needs some support there. More technical help, training to visit Boston, always learning from you, more networking. This is fantastic. I feel encouragement. Yes, we can give you that. I think we can give you most of these things, not the vodka. More HIV training. The National Institutes of Health would not keep our funding going. Yes, the stigma toolkit. Yes, 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 yes. What else? Anything else that you feel like you need? Some sage advice. I'm so sorry that things are sliding to the bottom. I'm trying to get to them here and it's making me go back. No. All right. Well, we saw so many things that we feel very confident we can offer you. And if you think of any more, pop them in that chat box, because Anna and I are now about to go into what we can offer you. And as we're going, if you want more things, if you have questions about all of the things, tell us. All right, Anna, let's take it away. We're going to talk about how we can support you in the months and year to come.
Yes, so NaRCAD will continue to support you after this conference. We provide virtual support through our toolkits on our website. We have pre-recorded webinars and videos and literature archives. We also offer phone or Zoom support. And finally, we are available via email and offer guidance, resource requests, peer connections, and troubleshooting. You can email myself or Anshul or send a message to narcad@bmc.org if you're interested in continuing the conversation with us.
Consider us your warm line, just no middle of the night calls, although you don't have our cell phone numbers. So hopefully we'll continue to practice healthy boundaries with each other. In the meantime, football chat is blowing up the chat box. Feel free to participate or talk about something else. Back to you, Anna.
All right, so you are forever connected to us. You've all been added to our mailing list so that we can keep you up to date on our offerings and events. If you'd like to opt out, please message Anshul. As Bevan mentioned, it's Friday is the deadline, not today. So you have a few more days to think about it. We never spam you. We only send things you need to know about what's happening in our community.
And want to say too, you can opt out on your own. If you start getting stuff from us and you want a breather, you can opt out and sign back on our website. So not to worry there. All right, back to you, Anna.
All right, so this is a screenshot of our homepage. If you haven't checked it out, I encourage you to do so. It has a fabulous 2-minute video about academic detailing that you should totally watch. There's so much great stuff on our website. We have toolkits, literature, tools, webinar recordings, conference recordings, and we'll tell you a little bit more about where you'll be able to find those in a bit. And it's just filled with some amazing tools. If you're not finding what you're looking for, please reach out to us and let us know. We'll curate something for you or point you in the direction of where it is.
And I just want to shout out to Anna herself. When folks have asked us, do you have a guide on how to make a detailing aid? Anna's like, no, let's make one. So we have all of these things. Do you have a guide on how to recruit new team members? No, let's make one. So truly let's make one. We want to do that as much as we possibly can. And back to the video, I know some of you may have seen this already, but it's really just 2 minutes. And so if you want to ever sell the idea of what's AD all about to somebody who you may want funding from, stakeholders, your leadership, it's a video about why people are passionate to do this work. And so many of you on this call were actually filmed for this in 2019 during our last in-person, but not our very last ever in-person conference. So please check it out. It's really, really terrific. We're so proud of it. All right, back to you, Anna.
All right, so if you're interested in learning more about virtual detailing, you can check out our e-detailing toolkit. If your program's not ready for in-person visits or you're looking to do a mix of in-person and virtual, then this toolkit's for you. We have a checklist for getting started, as well as a frequently asked questions sheet, a webinar on e-detailing, and all relevant literature is in there. It's filled with some really great stuff. And we're always happy to chat on the phone if you'd like to discuss things further.
All right, so we announced this. We do this every year at our conference. We announce the very first of the year ahead's detailing training. It's not open yet for registration, but put it in your calendars, January 15th, 2022. It's going to sell out fast, but here's the thing. We are going to have plenty of them over the year. And if you are, panicking because your grant says you have to be trained earlier, we will find ways to meet you where you're at as best we can. We also do run customized training. So if you have a group of 12 or more, we are able to do a virtual customized training. Fingers crossed that we can come visit you in person, probably as of maybe the summer at earliest. So if you want to fly us out to come hang out and check out your part of the world, we would love to be there. This is, again, all up on our website, and Anshul has been kind enough to pop that in the chat box. Back to you, Anna.
Yes, and we encourage you to join us in our 2022 academic detailing roundtables. So this is similar to the one you just participated in. These roundtables are a chance for you to connect with each other in these small breakout groups. We usually pick a topic for the session. We typically do 10 minutes of level setting, and then the majority of the time is spent in those breakout groups with your peers and in a large discussion at the end.
And it's different every time. Sometimes we talk about empathy. Sometimes we talk about a specific clinical topic. Sometimes we talk about getting in the door and how it makes us want to hit our heads against that door. So please do join us. Anna, over to you.
Another one of the ways that we've been connecting and getting our community to connect and chat with each other is through our Peer Connection program. So we curate matches based on the interests, topics, and experiences, and you meet one-to-one with your match several times over a 6-month period or so. It's a really fun opportunity to engage with someone and bounce ideas off of one another. A lot of times, as we know, detailing can be quite isolating, so it's nice to have someone there that you can chat with and share and reflect. We'll have more information about our 2022 cohort in the coming months, so keep your eye out for that.
And Anshul is dropping links like it's hot. So if you're afraid that you can't capture all of those, we're going to send them all out in a final email as a separate document. So don't go bananas trying to grab these all right now. And Narissa, thank you for saying this, that the Peer Connection is a fun, great program. We're so excited for 2022 because it's going to be our 3rd year of doing it. And Anna's going to share some highlights from the program this past year.
Yes, here are some testimonials. I am going to read one of them, and this is one of our favorites. 2 minds are greater than one, and this is a great way to connect with other detailers to help each other through this journey because we are on a journey.
Awesome.
Mm-hmm.
All right, Anna, back to you.
Yes, we also encourage you to connect with one another on our discussion forum. So this is a space to continue the conversation, ask questions, connect with peers. It's super easy to sign up. It only takes about a minute. We have several different threads that you can add to. We've had detailers share about their favorite and funniest detailing stories. People have detailed in barns with baby ducks and parking lots and singing groups. So we have some really great stuff on there. And you can also post additional questions you have for our presenters from the conference and continue the discussion there.
And I'm hearing from a couple people direct messaging me, is it okay for me to share this resource that we talked about in the roundtable? Yes, yes, yes. You can share it in the chat box, and you can also post it on the discussion forum. So please do take advantage of all of the different options that we have here, including the conference hub. It is getting bigger every year. We've been building it for the past 7 or 8 years. And the idea here is the stuff you learned the past 3 days is not just limited in terms of its impact and content and ability to kind of take it all in to these 3 days. There is stuff that we've connected folks with who say, do you have anything about smoking cessation? And we can say, hey, at the 2018 conference, a keynote address was about smoking cessation AD. So do check out the archives. And we are proud to say that every year, we are able to get up all the content from a conference within a week, usually way less. So if you're excited about something you saw, if you saw a panel that you're really pumped about and you want to share the link with somebody that didn't get a chance from your team to make it to the conference, it will be here and you will get a blast about it. So you can check it all out. If you're looking for something you can't find, just tell us. And Effie is saying, how do we find the unads or the detailing aids? Those are in our materials toolkit. So we encourage you to pop on over to NaRCAD.com and check it all out. All right, so we're getting ready to wrap up. We're super, super early, which is just so delightful. You guys are gonna get some time back in your day that you probably weren't expecting, and that's because all of you were so efficient. But we want to take some time to let you ask any questions that you need to ask in the chat box. So as we say some final words, we really want you to have this chance to say, ask anything that you want to while we're all here for you. And if you can't think of anything right now, you're fried and zoomed out, we're right there with you. We are always, always, always here. Again, not like Brandon Misrak with a warm line and a cell phone, but as close as we possibly can be. I want to say a couple closing words, and then we're going to give you time right here to fill out your evaluation, and you'll still be done a half an hour early, which is delightful. So we'll tell you about the evaluation in 1 second. We really, really want to thank you for spending good time with us. You guys are stinking amazing. I cannot tell you how excited I am, all the wonderful energy from the past 3 days. It's beyond anything that we could have possibly hoped for. You guys give us so many ideas as this small but hopefully nimble resource center that started out with 1 person, a person and a half, then 2 people, and now we are 4. So look out. We are so happy and privileged to be able to support you in your journeys. We're starting our 11th year, which feels really terrific. We're getting into the preteen adolescent years. And we need you guys to help us figure out if we're going in the right direction. We listen to everything that you say and try to incorporate it as much as humanly possible. So please do not be shy. You can reach us at narcad@bmc.org. Anshul will pop that right into the chat box. And we are so excited to see you at any point of next year. And I hope that you'll stay in touch. Anna, over to you to wrap up the evals.
Yes, please take our evaluation for the 3rd day of the conference. If you filled out days 1 and 2, we appreciate you. If you haven't had the chance yet, it would be lovely if you could fill out the evaluations for days 1 and 2. Anshul will pop that link into the chat box. We value all of your opinions and we want to hear from you. Again, we'll pick a winner for our $50 raffle and we'll send you an email if you have been chosen.
So if you hang on 1 second, Anshul just dropped share your feedback here, please. We don't want to sound desperate, but we need this information to do better for you guys. So take your time to fill it out. If you didn't get a chance to do 1 and 2, please hop back to that. We really, really value your support. It is invaluable to us. And we read every single comment, whether it's, you know, back when we were in person, someone didn't like the sandwiches. Hey man, we changed the sandwiches. If you are upset about something that happened, we want to know, we want to reach out to you and figure out how we can make it right. If you loved meeting somebody and you're like, what was the name of the person who did this thing? in Iowa, hey, we're going to figure it out for you and get you in touch. So please, please let us know what went right, what maybe fell flat, what you would suggest for next year, and take your time doing that. Vishal, always wrapping things up about the food. Did someone say sandwiches? Please enjoy your evening when you're done with your evals. Get yourself some sort of reward for sitting for 3 days. I know it's tough. We try to make it as easy as possible, but hopefully this will be the last time you'll have to do an evaluation from just a virtual vantage point. And here to wrap everything up, I want to turn it to Dr. Jerry Aborn, who has joined us. Dr. Aborn, would you like to share some closing words for our community?
I sure would, Bevan. And I want to start by thanking you and the whole NaRCAD team, as well as Mike, who, as you said at the start of the day, had to be away because of a death in the family. We've been in touch. He's doing okay. And it was a person who had a good death, who was elderly and chronically ill. And so it's not as if it touched directly somebody in the prime of life. But I know that Mike's thinking about us as we wrap this up. And he, like I am, would be so delighted to just see how well things have gone. I think it is just so impressive what Mike and Bevan and everybody at NaRCAD has done in recent years to really move the ball forward so magnificently and to create an organization like NaRCAD and events like this where, you know, we're all kind of struggling here in terms of trying to improve medications and get docs and other prescribers or healthcare professionals to do what we know they would like to do, if only they knew how. But it can, as we've heard a lot in the last couple of days, be a lonely effort, and sometimes thankless and sometimes frustrating. And so what's so great about what the NaRCAD team has done so beautifully, as you've seen in the last 2 days, 3 days, is to be able to bring us together and enable us to be there for each other, not just to share neat ideas, of which there has been a ton in the last 3 days, but also to know that there's other people out there doing this zany thing just like you are, and that we are here to help each other, whether it's with materials or encouragement or tips, or just knowing that there's other people like you who are working in this same area. And that is something you can know intellectually, but it really helps so much when you actually experience it, as we have together in the last couple of days. So with enormous thanks to Bevan and Anna and everybody else on the NaRCAD side, as well as Mike, of course, for, as you can all imagine, the effort that goes into putting together such a seamless and efficient and fun 3 days. I, for one, am very grateful to them, but also to all of you who are participating for, you know, taking this kind of offbeat idea of mine from the 1980s and really making it blossom internationally. And, you know, so much good is being done in terms of improving patient care, helping healthcare professionals to be all we can be, if only we knew what the right thing to do was. And it has just been really, really rewarding for me to see, but more importantly, I hope it's been useful to all of you. And I cannot wait to see you all in a year and interact with you in the months between now and then. So with that, I will hand it back to Bevan.
Thank you so much, Jerry. We are just, what field is there where you're like in touch with the person who birthed all of the ideas? It's such a delight to be able to do that. I want to thank Jerry, again, thank Mike. I want to thank Anna, our amazing manager of education and training. I want to thank Anshul, our program coordinator, and I want to thank Julia and Teresa for being our behind the scenes events coordinator. We couldn't have done this without you all. Thank you so much. And I want to thank all of you for being here and showing up in whatever way you could. If you had to miss a meeting to be here, we thank you for being with us. If you were only able to sneak in one session, that's good enough for us. We just want to connect with you. And that's the beauty of the virtual world. As much as it has its cons, you're not sitting in a stuffy, meeting room hall being like, oh, I don't know if I want to go to the next session, but I don't know what to do with myself. So in a way, we can see the pros. Having said that, we want to see you in a non-stuffy meeting hall. We want to have some cocktails and some hors d'oeuvres with you and just get back to a sense that we can all be in person and really appreciate each other. So thank you again. If you need anything, email us. If you have your evals open, go ahead and we'll say sayonara and see you in 2022. Thank you so much. Good night.